Good morning, everyone. Members of the board, public, staff. I want to ask us to please turn off our cell phones to silent and make sure they're off the table so we can avoid feedback noise. I'll do that myself. You may notice board members accessing their laptops during the meeting. They are using the laptop solely to access board materials that are in electronic format. This is an official business meeting of the Medical Board of California. As such, disruptions of the board's business will not be tolerated. We have designated time on the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful of the need to conduct the board's business. Should anyone disrupt the meeting, I will ask the person to conduct him or herself in such a manner that permits the board to transact its business. This meeting will be available via teleconference. Individuals listening to the meeting will have the opportunity to provide public comment and will be assisted by the moderator, who will be facilitating the teleconferencing process. For those members of the public participating via teleconference, please wait until the monitor has introduced you before you make your comments. To request to make a comment during the public comment period, please press *1. You will hear a tone indicating you are in the queue for comment. If you change your mind and do not want to make a comment, please press the #sign. Assistance is available throughout the teleconference meeting. To request a specialist, press *0. Each person will be limited to 3 minutes per agenda item. However, during agenda item 11, public comments on items not on the agenda, the board has limited the public comment period for individuals on the teleconference to 20 minutes. In addition, public comment from individuals here at the meeting will also be limited to 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. During the public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and those in the audience. After 10 minutes, no further comments will be accepted. Sivang, hello, will be assisting me with receiving the public comments via teleconference during the meeting. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand and you will be recognized. I would like to remind all speakers to complete a presenter's slip so I can call you by your name at the appropriate time and that the record of this meeting can be full and complete. Please give the speaker slips to Ms. Lisa Toof. Lisa, can you identify yourself? Hello, good morning.
Good morning.
I will do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make a last-minute comment. But we ask that you fill out a speaker slip after your comments so we have it for the record. I want to remind all speakers to stay on topic and keep your comments to 3 minutes or less. We may take some items out of order to accommodate today's schedule. We're going to move on to agenda item 11, public comments on items not on the agenda.
Roll call.
Oh, roll call, sorry. Of course. Ms. Toof, can you please call the roll?
Absolutely. Dr. Levine? Dr. Bishop?
Here.
Dr. Gnanadev?
Here.
Dr. Kraus?
Present.
Dr. Lewis?
Present.
Mr. Louie? Ms. Pines? Present. Ms. Shipsky? Ms. Wright?
Present.
Ms. Yaroslavsky?
Present.
Dr. Yep. And Mr. Serrano-Sewell.
Present.
Thank you.
We have a quorum. Thank you. Moving on to agenda item 11, public comments on items not on the agenda. Are any comments from the public, from those present? Any comments from the phone?
And if anyone does have a comment, please press star, then 1. We do have one. It comes to the line of Genevieve Clairview. Please go ahead. Possibly your mute button's on.
Hello, you hear me?
We hear you now.
A couple of days ago, we went to see a physician, an expert in endocrinology, and before he will even see my daughter, he gave her a paper to sign. And my daughter has an insurance and everything. Require authorization for automatic credit card payment of $300 or a signed check.
Genevieve, please don't say anything about a physician that may come before the board for
I did
discipline.
not give the name of the doctor. I'm just saying, is it legal to get, to me it look like extortion, and what can be done about it?
Genevieve, we'll go ahead and get back to you on that. I think we have your email contact information, and I will actually
because,
ask.
I think that's very scary, and I saw few other patients who were willing and signed it. We refused, of course, and we were not seen, but I would like to know from a both ethical and legal point of view, can it be done when you are fully insured?
Right. So I'm going to have Miss Katie, our enforcement manager, get with you. And actually, I believe we can probably even possibly do that on the phone right here just to get your contact information. We'll put you on mute for the meeting, though.
Okay, thank you.
Thank you.
Are there any other comments from the teleconference?
No further comments.
Okay, before we move on to our next agenda item, colleagues, we're going to go finish up the executive director's report. There's a few more items before that. In consultation with Dr. Levine, I'm going to make some following announcements on the committee assignments. The first one being Dr. Lewis. Now that Dr. Ganandev is serving as vice president, we are appointing Dr. Lewis as chair of enforcement. And Dr. Ganandev is going from enforcement committee to licensing, and we've asked Dr. Yip to serve on HPEF. So thank you all. You'll recall that one of our board agenda items is to take another look at the committee structures, and that's something that I'll be doing in consultation with the executive committee when we'll have some announcements at our October meeting. But now continuing with our executive director's report.
Okay, thank you very much. Good morning, everyone. I just had a few things yesterday. We needed to get rid of the business that we had to do on my report, but I wanted to give a little bit more of a summary update on some items. I'm not going to be going over the administrative licensing or enforcement summaries. Those are all in your packet, and I would encourage you to look at those to get updates on what's going on with the board. But I did receive one question from a member, and I wanted to actually provide clarification on that. On page 8B, it'll be BRD 8B, 8. The amount of the Attorney General line item actually will remain the same, even though the board investigators have gone over to the department. The AG's office actually has their own line item in their budget, and that line item also includes vertical enforcement portion. So that will continue to be paid directly from the board. For fiscal year 14-15, we will provide 2 budget reports for enforcement. One board enforcement report will be for the medical board, so that would still include our central complaint unit, probation unit, discipline coordination unit. And then the other one will actually be for the health quality investigative unit, because they actually have a budget just like we do with specific line items, and we'll be providing updates on that. That first report actually will be provided in October. I also wanted to let you know that we have actually entered into a contract with a travel agency to do the travel for state employees. This will require users to use this new travel agent beginning in November, and we will be providing information to all the members because you will have to go in and sign up, log into the system, and activate your usage, and Ms. Rayo will be assisting each of you with that. And then I wanted to take one last moment to really thank staff. For most of you that have been on the board for a while, you know that July 1st is a deadline date for us in licensing. And this year it was a little bit more difficult because we did have a new system that we were dealing with and contending with on this issue. And our staff put in a lot of overtime, and we were able to actually license the individuals that needed license by June 30th, with the exception of those that didn't get in their applications on time or sent them in, a couple days before the deadline. But even with those, we were able to make sure that all of the applications were reviewed. Anybody outside of that time frame, it was actually because they hadn't submitted the information to us. There were a lot of other units as well as licensing that assisted us in that, and I just want to take a moment and thank them. Last week, I traveled to Washington, D.C. to represent California at a meeting hosted by the Department of Health and Human Services. The meeting was entitled Advancing Policy and Practice, a 50-state working meeting to prevent opioid-related overdose. It was held the 17th and 18th, and the meeting was very well attended, and almost every state was represented. For California, in addition to myself, it was Virginia Harold, the Board of Pharmacy Executive Officer, and Jackie Dower from the Department of Public Health. The meeting actually started out with an overview of the epidemiology and evidence base for interventions. Both the Deputy Secretary and the Secretary for the Department of Health and Human Services stressed 3 components addressing this issue, and each of these issues was then a main focus of the meeting. Those 3 areas were provider oversight, so including collaboration and accountability to ensure patient safety, prescription drug monitoring programs, including increasing access and the use of these PDMPs, and then prescribing guidelines and providing education. It was very interesting to see where California actually fit into this, these 3 items, as well as with other states. In some areas, we obviously were well ahead of some of the other states, while in others, especially in like the PDMP and the newness of some of the abilities, we weren't as far as the other states. So what we did is they had a couple states make presentations on what they had done. During the 3 breakout working group sessions, the region states got together and discussed what they have each done in the areas and what still needs to be done. The Department of Health and Human Services is going to be gathering all the input, and they will provide an overwork of the work that was completed at that meeting, and I will provide that to members as soon as I receive it. The meeting actually ended with the Chief of Staff from the White House of the National Drug Control Policy talking about their goals, what has been done so far, and what still needs to be done. There were a lot of take-homes that I brought back, and I will be discussing those with our prescribing task force in the future. At the meeting, we were provided with a layout, and I think that was handed out yesterday. I hope everybody had a chance to look at that. It's this document here. And this really shows where we fit with the rest of the nation as far as with the information gathered by the CDC. The board still intends to have another joint forum in the future after our prescribing guidelines are revised, and at this meeting, Ms. Harold and I actually identified some future speakers from this meeting that we believe we would like to invite out to California to speak, so that was beneficial. If you look at this document, it actually shows that we actually rank very well amongst the states. For those of you that had a minute to look it over, we actually have the 40th highest drug overdose death rate. We actually show for each 100,000 people, this again was from 2011, that California had 10.7 overdose deaths. And this is for all drugs, not just opioids. West Virginia was there. I don't know where they rank, but I would assume they're the top. They actually had like 36.3 drug deaths. Again, I think these, we don't want these to lull us though, because again, the statistics can be read in a number of ways, and we're such a large state when you're looking at it. If we probably just pulled out LA County and possibly compared us with West Virginia, we might not look as well. I don't know if that's true, but it was interesting. And then also California has the 2nd lowest opioid pain reliever prescribing rate in the U.S., and that was another thing that was kind of, from our perspective, was an interesting statistic. Yes, Dr. Gunn?
Ms. Kashmir, have you provided that information to the media? I'm just tired of our media writing only one way and just keep beating up on the board. So that's why I think this is the type of information we should provide it to the media, so
And
they
we
can
can make sure
look at
that
it
that
too.
gets out to them.
Yeah.
And then on this same issue, I wanted to update you on the California Department of Public Health's opioid overdose work group. That's another work group Ms. Simoes and I are on. We've notified the members in the past during the board updates, but I wanted to give you an actual update from our last meeting because it really impacts us. This group, it's made up of state agencies, including other boards of the department, all the dispensing and prescribing boards, as well as several units within the Department of Healthcare Services, the Department of Education, county local health officers, the Emergency Medical Services Agency, the Department of Justice, and they're going to be including others in the future. Others have been invited, they just haven't attended yet as well. But at the last meeting, it was recommended that the board's prescribing guidelines be the actual kickoff for this group. And they plan to do a large press conference as soon as our guidelines are approved. The release of our guidelines will be the catalyst for all the agencies to put their outreach plans into play. Tomorrow you will hear, or actually today now, you will hear the status of the guidelines during the task force update. There's a lot of work to be done with this group to ensure that we have a united front, but over the next few months, that is what we'll be working on. Also, as stated in the update in the packet, the board is going to be providing our free CME that we got the grant for on extended release and long-acting opioid prescribing on September 19th in Los Angeles, in the Los Angeles area. For those members that are down there, I'd really recommend that you attend. We're going to be doing a lot more outreach. We're working with the LA County Department of Health as well as the Emergency Medicine, the American College of Emergency Medicine, I couldn't think of the C, for outreach in the area as well. And then lastly, we are going to work with Mr. Small, his presentation yesterday on the CARES system, and in the future what we hope to do is actually at our board meeting allow the opportunities to physicians to come in whatever area we are and provide us the documentation so we can actually verify their information, package that up, and send it to the Department of Justice. We're also going to be offering that opportunity within our office. So I know that that won't reach other than Sacramento, but at least that's one more step to getting more individuals registered for CARES and using CARES, because I don't want anybody to think that CARES is not valuable. Even though CARES is outdated and it has some issues, CARES is still a tool that physicians should be using as much as they can to look up the physicians, and we want to make sure that people get registered. At least that will be one step forward for that January 1st, 2016 date. So with that, that concludes my report unless anyone has questions.
Members, are there any questions? Ms. Yaroslavsky?
I want to thank you very much, Ms. Kretschmeyer, for that report. I'm just wondering if there's any ability, in addition to using the Sacramento office for doctors to sign up and register for CARES, if there's any ability to use any of the district offices for the same.
That would actually be something I'd work with Mr. Gomez on now. I don't know this resource limitation in some of those offices with the only having one clerical in each office, because it really would be that individual. But I can talk to Mr. Gomez about that. Dr. Levine had actually brought that up too, so I will be
What I was
talking.
thinking specifically was as part of an outreach opportunity in different cities where we have those offices anyway, to use them as a structure with our staff to, as they're doing outreach, maybe to do that as well, maybe once a month in different
That's
areas.
actually a good idea. Anytime we do outreach, we'll have a person there that can take on the physician, because actually Ms. Katie and I are both traveling quite a lot in the next couple of months, hopefully if we get approved, to do some outreach in the Southern California area.
Any additional questions? Yes.
As I mentioned, Kim, yesterday, for CURES registration, is it possible for a physician to get on the website with just a few numbers, California license number, California driver's license number, California address, and the DEA number, can automatically populate and get registered very quickly rather than go through the entire process of waiting 3 weeks to get something back? And the second one, you got to continuously work with them, is to get the real-time information for physicians' offices. These two are very important. Without that, CURES just gives a false sense of security. It does not give really what we need.
So on both of your questions, in regards to the first question, I believe that's going to be available with the new system. For right now, we're not going to be able, even if we gave them a flat file right now, they don't have the ability for a person to log in and use our flat file to populate their information because the system's just not there. I think that's obviously what they're pushing for the July 2015 date. I would hope they could do that sooner. I think the capability may be there, and the more we work with them, I think that's a possibility. In regards to your second issue, I was talking to Ms. Pines last night about this. As far as real time, there's two timelines I want people to be very clear about. The first time, real time, and it depends on which one of those timeframes you're talking about as to the usability. First of all, for the real time, as far as a physician logging into the system, because Mr. Serrano-Sewell came to see me today as a physician, and I want to check his CARES report. Once I'm registered, I can put that in, and as you heard from Mr. Small yesterday, the return on it could be seconds, or if you're a large user, it could crash the system. So that's something, obviously, in the new future that they will be fixing. But I know we run reports, and they actually come back quickly. So it is possible. I don't know what percentage of individuals have crashed the system, but I do know that we get reports timely. So that will be coming back quickly. As far as real time with the data in the system, as long as the law, which currently states that a pharmacist has 7 days to enter the prescription into the system, as long as that law stands on the books, it will never be real time in that the information is in there. So if I went today to 5 different prescribers, that's not going to show unless the pharmacy actually is one, maybe a smaller one or maybe a larger one that has the ability to put it in there quickly. So until the law changes to require that, it will never be a real-time system with all the information in there. One thing to add is that at this meeting, it was interesting the vast variety amongst the states as far as what real-time means to them on that end of it, as far as entering the data into the system. And it goes as far as being a lot like us with 7 days. There's a lot of states like us with 7 days. There are a number of states now that have moved it to 24 hours, which is interesting. That's actually I think that would be a great step. And there was one state down that has it down to 5 minutes. So basically what that means is their system has to be running. I'm looking at our IT guy that will be speaking in a minute. Has to be running to where it actually, once you basically fill that prescription, enter it into your system to charge the person, it has to be matching up with the CARES system.
Thank you.
So let me ask you a question with what you just were saying. So the issue now is for the physician to sign up for CURES, to use it as a tool. Will we ever get to the point where the consumer is the one that needs to have a number or some identifier so that when they go to the pharmacy and they input that number, that automatically it goes into a system? So that when they go to 5 different pharmacies for the same drug, while they're doing drug-seeking behaviors, that there would be a way of that popping through?
At this time, it's really driven by the patient's name and DOB. At this time, that's what's entered in there. One thing I did mention at the national meeting that I was at is that until we get a national provider identification number for all patients, it's hard to track people. As we've seen in enforcement cases, you go in as Jane Smith to one facility, you go in as Jane Doe to another, and you go in as Jane Jones to another. There's really no way of getting around that. So until there was a national provider identification number that everybody in the United States had.
Thank you. Doctor?
I can't help but comment that the ability to create what we desire is not rocket science. You can't go to 5 different branches of your bank on the same day and withdraw $200 from each bank if you've got a $400 balance. The technology has existed for a long time. It's just a matter of dedication of dollars and resources to build it out.
We have Dr. Bishop.
Kim, I've heard now on 2 subsequent days that because the law is such, we can't do something. Well, it begs the question then, what are we going to do to get that law changed? I think all of us here would agree that 7 days is way too long. It isn't what the intent the physicians had, I think, and probably law enforcement as well. How do we as a board now try to push this through, get the legislature to pay attention to this? Because we need, this is our, we're their consultants, and we're telling them we need to do this. How do we forward that idea?
I think that,
Sure. I mean, to answer that question, very good question. One, I think the board needs, it's been discussed and there's been a lot of comments at previous meetings since I've been on this board about doing a legislative day in Sacramento, reintroducing ourselves as members to the electeds in Sacramento and their staff, very important. That's one. And if we collectively decide that to meet consumer protection and the public's expectation, physicians' expectation of Cures 2, with all its issues, that there needs to be some legislative fixes to bring on the technology that other large institutions have, we should do that. And that's a decision we can collectively make. I think we're going in that direction, and you know, we should do it.
And that is something, it's something we need to work with the pharmacy board on, kind of like Mr. Serrano-Sewell was saying. We need to work with our partner board because it impacts them greatly and their licensees. So we need to work with them on it. And I think we're going to have pushback on that law until we have a system that will actually be able to do that. So I think in the next 2 years, at the end of getting this care system up to date, I think that that's where we need to work with the pharmacy board and push that agenda.
If there's no other comments from the members, we'll go on to our next our next agenda item, returning to the agenda. And that is agenda item 12, update from the Department of Consumer Affairs. There'll be a discussion on a Breeze update. We don't need public comment on a report item. We're not taking action.
They're still entitled to comment.
Sure. Was there any public comment on the non-action item on Ms. Kirkmeyer's report? Just one moment, Ms. Sorry.
No problem.
Any public from those present? Any comment from those on the phone?
Pardon me. We do have one queued up. It is Genevieve. Please open. Your line is open.
Yes. Few weeks ago, it was a webcast with the CDC and an American healthcare journalist. You know, they share the information. Yeah, you pointed out that California was the state was the lowest utilization of opiates and so on. And I think it's something in that picture was very concerning. We are one of the lowest utilizing states, but we have more deaths caused by opiates. So, and that, you know, when the article in the LA Times last December, you know, made that totally misrepresentation of the situation, nobody looked at those stats. And that's a huge concern. Also, when you're talking about California, the 4 states identified in that article represent the same population than New York, Texas, and Florida. So a lot of the information is not used to really point out the issue. So it's something definitely extremely wrong when we are one of the states who use the least, we are the largest, and we have the most dead. So I think that's maybe what we need to really look in detail. And I think it will be very good, I think, if all of you saw those stats, because they are very impressive. And myself, you know, I was very surprised to see how little, utilization of opiates was in California. So I just think, and I think the idea of having a legislative day is an excellent idea, and I think it would be great. Thank you.
Thank you for your comments. Are there any other comments from the phone? Just the one.
There are no further questions or comments.
Thank you. Item 12, update from the Department of Consumer Affairs. Ms. Lally.
Hi, good morning. Christine Lally, Board and Bureau Relations for the Department of Consumer Affairs. Always a pleasure to be with you. Just wanted to start with a congratulations to the new board leadership, President, Vice President, and Secretary. I've had the pleasure of working with you over the past year and look forward to our new challenges. And also wanted to, on behalf of the director and the department, thank Dr. Levine for her extraordinary service. She, again, has been a pleasure to work with. And on the note of new leadership, as many of you know, and it bears worth it. Sorry, it is worth repeating. Always worth repeating. Good news that we have new leadership at the department level, and we said goodbye tearfully to Department Director Denise Brown after 30 years of service to the department on July 3rd, and we welcomed our new director, who is who you probably recognize, Awit Kadani, and our new Chief Deputy Director, Tracy Ryan. And as you probably know, Awit was previously the Chief Deputy Director of the department, and Tracy was previously the Deputy Director for Legislation. So familiar faces for probably most of you. Later in the agenda item 19, my colleague Michael Gomez will be giving an update on SB 304, which I'm sure you're all interested to hear about, so I will let him do that. But at the board's request, I know that you're interested in an update from the Breeze project, and I have the pleasure of introducing Jason Piccioni, who is the department's Chief Technology Officer and my personal Breeze guru for all of my Breeze questions. So I will turn it over to Jason.
Welcome.
Thank you. Good morning, board members of the board, Ms. Kirkmeyer. My name is Jason Piccioni, and as Christine said, I am the Chief Technology Officer for the Department of Consumer Affairs, as well as the Breeze Technical Project Manager. Thank you for having DCA and Breeze here today. Stakeholder involvement and commitment is one of the most critical components for success. I would like to give a brief update of the Breeze system and then to do my best to answer any questions you may have. My intent is to provide information that is most relevant to the Medical Board of California. I realize that an area of interest for the board is the schedule to get requested fixes and changes completed. I can share the schedule for the next 3 production releases for the Breeze system. Production release 1.14 is scheduled for August 14th, 1.15 is scheduled for September 19th, and production release 1.2 is scheduled for early November. As was reported by Ms. Kirkmeyer in your May quarterly board meeting, the scheduled production releases for the first part of 2014 were April and August. So this new schedule, or this modified schedule, represents an acceleration of scheduled production releases. The DCA has identified the need for a more robust and agile production maintenance structure. To that end, DCA is in talks with the contract integrator to establish a higher capacity, dedicated production maintenance team. Though the exact number of resources is yet unknown, a DCA-directed team of dedicated expert contract integrator staff will increase the throughput of our production maintenance. The intent of this effort is to run higher capacity releases on a 5 to 6 weeks cycle. Another key feature of the current discussions is to accelerate knowledge transfer. DCA believes that the sooner we can perform critical development tasks in the area of configuration, Versa Online Client Text, and build and deploy, the more responsive our maintenance structure can be. Another area of keen interest for this board is the usability of the Breeze online experience. A rough definition of usability is the effort to make products and systems easier to use and matching them more closely to user needs and requirements. Myself, as well as DCA, just like this board, have identified many opportunities to increase the usability of the Breeze online system. We want to make the user experience better. This effort, our effort, is illustrated by 2 current work efforts to improve usability. These efforts include deleting the existing Breeze homepage and having the current Breeze login page act as the initial landing page for the Breeze system, eliminating an initial, potentially confusing upfront page for users. To redesign the homepage with better instructions, increased usability, and more visually appealing. To provide a scrolling announcement section on the homepage that can be updated by staff and provide announcements for the public. To provide a dedicated URL for license lookup that will allow users to click through directly to license lookup from any website without having to visit the Breeze homepage and the initial pages that may be unnecessary at this point. The last two are a little deeper technically, but I'll share them. We're going to parameterize links to pre-populate drop-downs in the searches, as well as parameterize links to specific resources. And as an example, we'd be able to go directly to a license detail page by including the license number in a link. We expect details from the contract integrator for redoing this homepage at the 7/28 Change Control Board meeting, and we expect the analysis for the remaining items that I've discussed presented at the 8/11 Change Control Board meeting. We believe this is our start toward a better user experience. Our efforts towards increased usability are structured by the Human Factors International, or HFI, and usability.gov standards for the web. At this time, I'd be happy to answer any questions you may have.
I know there will be. Ms. Yaroslawski, to my right.
I want to thank you for that report, and I'm glad to hear that you've been so responsive to the issues and concerns that we've all had. I would just ask that when you're doing your changes, that maybe instead of using IT gurus to fix everything, that maybe you use a few stakeholders, so that if you were to use some people that just use the page for what their needs are versus people that know what they're doing, that also might help drive the conversation as to what is missing, where the missing or weaknesses are in the system. But I want to thank you very much for what I'm hearing.
Very valid point. Thank you.
Thank you. Doctor?
Thank you for the update. Hopefully fix the bug which stopped me from renewing my license last year. Once you're changing something, it just goes off. If you're just going through, it's a breeze. Can get it done. But if you want to change an address, then it's not. So it has been tough. But my real question is, are you working with Cures 2.0 to see how we can populate when you go to register? I mean, I need to see how you guys can work so closely together that it becomes very easy to register, easy to look up and all that between Breeze and Cures.
Yes, there is currently no interface between the two systems planned. However, the need has been identified, and the Department of Consumer Affairs has provided the Cures project with the Breeze data dictionary so that all data elements are known to that project, because clearly an interface in the future at an unknown time will be required. So we've provided them the information and identified the need for that interface, so that can be included in their planning.
Any other questions or comments? To my right? Okay. Thank you, sir, for that report.
Thank you.
Are there any other updates from the department? Yeah. Thank you. It's always good to see you. Thank you. Yes, comments from the public?
Good morning. Yvonne Chung with the California Medical Association. I just wanted to, I'm glad some of the issues that we were going to bring up have been raised by board members as well. The only other item that I wanted to make a request for was the ability for Breeze to show applicants where they were in the licensing process. And as you know, prior to the implementation of Breeze, the medical board had actually developed a pretty good way of allowing applicants to check it. And we're actually getting a lot more calls now because applicants are having a really hard time figuring out where their application is in the process. The medical board staff has been great about sort of providing back office assistance, but I know it's not a good use of our time, and it's not a good use of their time to constantly be checking something that previously was available. And I understand that the medical board staff is developing kind of a workaround, but I would really push to have that included. I understand that's not really part of the system going forward, but that would be a huge help for us. And we would support the comments regarding integration with Cures. Ultimately, we'd like to see a system where physicians can be registered for cures at renewal or when they apply, and it's a seamless process. And we'd be happy to participate in any kind of usability stakeholder groups, or at least having an option for physicians to comment immediately after they've used the system regarding what exactly their issue is, because currently they don't have an option, so they just call us. Thanks. Bye.
Thank you. Dr. Lewis?
I just have a brief question. Maybe you've answered this before. Is there a difference between the timeline for a brand new applicant to California in the Breeze versus renewal? Are they handled differently? Or is it the same timeline to completion of the application and entered into Breeze?
Ms. Kirkmeyer?
Yes, actually, they're very different because the application process, you actually have to primary source all of the documents, and they're two totally separate transactions. So even if an applicant goes online and fills out the application portion online at initial licensure, that still has to come in with all the documents, has to be reviewed. And as we've said, we're currently processing about 45 days. We review it at 45 days after receipt, and about 10 to 12% of those are complete, and they can get licensed, and the other ones have to have a deficiency letter. So that's the timeline for initial application. For Breeze online renewal, depending on if you run into any trouble, as Dr. Gonadev had with an address change or not, your renewal could take about 20 minutes, I think, for Dr. Levine for doing it online for your renewal. If you mail it in, it's going to take a lot longer than that. It could take probably about 4 to 6 weeks. But if you do it online, it's about 20 minutes, as long as you don't run into any problems.
So part of our outreach to new applicants is really enable them to have a very complete and robust application. Otherwise, they will be receiving multiple letters.
Yes, and I'm happy to report we actually just hired a student assistant who is working from a younger perspective in putting together a video actually to walk an applicant through filling out every step of their application with questions that we will be posting online.
Oh, good, thank you.
Thank you. Are there any other comments from the public on agenda item 12? Seeing none, are there any comments via teleconference? Oh, and we'll go to Dr. Yip.
There are also factors that is beyond control, such as there are also factors beyond control, such as like fingerprint clearance and all that.
Absolutely, yeah, all of that weighs into it. Our fingerprints, if they do live scan, they come back usually pretty quickly, unless you're a surgeon where your fingerprints may have to be done a couple times. But the out-of-state ones take a little bit longer through the process.
Thank you, colleagues. Any comments on the phone?
We have no comments or questions.
Thank you to the both of you. Appreciate the update. Moving on to agenda item 13, update on the Health Professions Education Foundation. Ms. Yaroslavsky?
Thank you, Mr. Serrano. So I'm very pleased to report that we've had a very robust season this year with Stephen Thompson loan repayment dollars. We all are aware of the fact that there's a mandatory contribution from the licensing fee, and we're more than appreciative of it, and I think it's helping the people, state of California, access quality health care throughout the state. And to that report, I wanted to let you all know that this season, this period of time, we awarded $31,835 worth of loan repayments to a total of 2,083 participants. It was 1,800 plus loan repayments and 268 scholarships. And interestingly enough, this season it was 75% were women and 24% were men. 24. So there's a percentage difference. So this is something new and different, which is, I think, very interesting to see how it's going. Also throughout the state, if anyone's interested, I have a report, but I'm not going to go through it county by county. Everybody was awarded. We received an extra grant this year from the endowment, California Endowment. We were very pleased, and it was a lot of work. It's reading applications. It's not as just perfunctory work as it has been in the past, but it's very rewarding, and I'm very pleased to be the board's representative, and Dr. Yip will be also to Health Professions Educational Foundation. Thank you.
Thank you. Thank you to the both of you, and thank you for that report. Are there any questions or comments from the members? Seeing none, are there any comments, public comments from those present? Seeing none, any comments on the telephone?
We have no one queued up for a comment or question.
Thank you. With that, we'll move on to agenda item 14, update on Education and Wellness Committee meeting. Barbara?
Thank you very much. Yesterday, we had a very robust committee meeting, and I want to thank staff for putting together such a good
That was a great
panel
meeting.
of informative guests. We had, the first presentation was from Dr. Barbara Hernandez, who's the Director for Physician Vitality at Loma Linda University, and she outlined the university's wellness campaign, which is designed to promote physician vitality across their career. The second presentation was from Dr. Michael Goldstein, who's a professor of public health and sociology at UCLA, and he presented his report on UCLA's initiative to become a healthy campus, entirely smoke-free, and they've put in through all sorts of different kinds of programs, healthy eating programs, and there's a major buy-in from the campus, which we're very pleased to see as a possibly a model for the rest of the state, if not the country. And then we had an excellent presentation from Dr. Jessica Nunez de Ibarra from the California Department of Public Health, and she gave us an update on the Let's Get Healthy task force, which the medical board is now a participating member. One of her main goals in this task force is the prevention of chronic diseases for a healthier California, because that's the way we're going to reduce our bills. It's not going to be by giving more money to insurance companies. It's going to be making sure that we can stay healthy and we don't need to go to the doctor. So it was a very interesting meeting. We also had a copy of the Public Affairs Strategies Plan, which was given to the committee prior to the meeting, and we're very pleased with the report, and I hope that people were able to attend, and if not, would access the data online. So thank you very much.
That was an informative meeting, and thank you for convening those individuals and having those presentations. Are there any comments or questions from the board members on that report? None. Are there any public comments from those present on this item? Phone?
We do not.
Thank you. With that, we'll move on to agenda item 15, update on the licensing committee meeting. Dr. Bishop.
Thank you. The licensing committee had two presentations. The first presentation was by Ms. Carol Clothier, American Board of Medical Specialties, Vice President for State Health Policy and Public Affairs, regarding ABMS maintenance of certification requirements. Ms. Clothier identified how the ABMS maintenance of certification has several elements that meet CME requirements for license renewal. Ms. Clothier advised the licensing committee that she had met with staff, and staff had advised her that the board may be able to accept ABMS maintenance of certification as meeting the board's CME requirements with an amendment to current regulation. I would like a motion to have staff review the current CME regulations regarding the feasibility of adding ABMS maintenance of certification as meeting the board's CME requirements, and have staff present the feasibility of amending the CME regulations, including draft language, if appropriate, to the board for review and consideration.
So moved.
Moved by Ms. Wright, seconded by Dr. Lewis. Discussion on the motion, members? Seeing none, is there any public comment on the motion? From those present, any comment from those on the phone?
We do not.
All those in favor of the motion?
Aye.
Aye.
Opposed? Abstentions? Motion passes. Dr. Bishop?
Thank you. The second presentation and discussion was by Mr. Warden on the minimum number of years of approved postgraduate training required for licensure and licensure exemption while participation in an ACGME approved training program in California, and to evaluate the pros and cons of increasing the minimum number of years for U.S. Canadian medical school graduates from 1 year to either 2 or 3 years, for international medical school graduates from 2 to 3 years.
Is that a motion? Oh, I'm sorry.
Not quite.
No, not quite. Almost
there. I didn't
Sounded
have my
like-
page tabbed yet.
Pardon me, Doctor.
FSMB is recommending 3 years for licensure. The minimum number of years for an ACGME or RCPSC accredited residency program is 3 years. In addition, the newly proposed FSMB state compact for licensure would require a minimum of 3 years and ABMS certification. The licensing committee made and adopted a motion to have staff proceed with interested parties' meetings to obtain input regarding the impact of extending the minimum requirements of postgraduate training for licensure in California. Does this require an adoption by the entire board?
Yes.
the interested parties?
Correct. The licensing committee made and adopted a motion, and not sure if that requires total board approval.
That's within the jurisdiction of the licensing committee. So if you would work with staff, and they'll convene that interested party meeting. It's consistent with the committee's desires.
Great, thank you. Well, that concludes my update.
Great. Thank you, Dr. Bishop. Sure. All right, thank you. Wanted to confer with council. Are there any comments from the public on Dr. Bishop's report? Seeing none. Any additional comments from the phone? Member, I'll get you. Thanks.
We have no comments in queue.
Doctor?
This is a very important item. I think I know licensing committee spent enough time yesterday discussing about how many years of training do you need to be licensed in California. I think so we need to, the interested parties meeting is fine. I think the board eventually need to take on and have a full discussion. My preference or my leaning is at least 3 years of training, but there are a lot of logistical issues. That is, when someone finishes 3 years of family medicine on June 30th, July 1st, that person need to have full-blown license. Mm-hmm. That means actually that license has to be there 6 months before, because that person will be applying for hospital privileges, and unless you're fully licensed, you won't even be in the hospital staff. So there are a lot of issues, but idea is excellent, because we are, it's just amazing to me that anyone with 1 year of training with multiple problems can apply in California for license. So I think there's a lot of work needs to be done, and I really appreciate Mr. Warden to really bringing this up and trying to take this on.
Just brainstorming that for a moment, Deb, I wonder if we could, at 2 years and 6 months, provide a provisional license with the understanding that if the training is not completed, that license would not be valid. So just brainstorming off the top of my mind.
Yeah, there are multiple ways. One state does for 30 months, and the other way is, I was talking to Mr. Warden yesterday, is that they get a training license, which will automatically turn into full license as the June 30th is done. So there are ways to do. Only thing it might jeopardize is that right now, third-year residents in internal medicine, emergency medicine, and family medicine can moonlight. That will take away. So the program directors might be happy that their residents can't moonlight, because the moonlighting hours are actually included in the 80-hour work week. So there are a lot. That's why there are a lot of issues we need to discuss with the interesting parties.
Looking forward to a robust discussion at that stakeholders meeting. If there's no additional comments, we'll move on to the next agenda item, item 16, discussion and consideration of disclosure of approved postgraduate training. Ms. Kirkmeyer.
Thank you. I'd actually like to ask the members to turn to the report behind tab 16. It has all of the information on this agenda item. In the board's Sunset Review report, the board actually requested that the Senate Business and Professions Committee consider elimination of the requirement to post approved postgraduate training on the physician's profile. The report stated that the board could not post the information on the board's website using its current information technology system. The committee response was for the board to discuss this proposal with stakeholders, specifically those representing consumer interests, and then report back to the committee. At this time, at the time of the Sunset Review report, we actually didn't have Breeze, and we weren't putting information into the system. However, with Breeze, we're actually now entering this information into the system from all the applicants that we've received so far on a go-forward basis. And actually, all of that information, including the location of the postgraduate training, the address, all of that information is now going into the system. So with this new information being entered into the system, we no longer believe that this requirement needs to be removed from the board's current statute. And actually, what we would recommend is that the board direct staff to no longer pursue the legislative change, but instead move forward working with a change for Breeze so that this information can be posted to the physician's profile.
Do you need a motion?
Yes, but let me maybe state it, or something. Is there a motion to direct staff to not pursue elimination of the requirement for the Medical Board of California to disclose postgraduate training on a physician's website profile? Is there such a motion?
So moved.
Ms. Yaroslawski, seconded by the doctor. Discussion on the motion, members, colleagues, questions?
It's an important information. I'm not sure why someone requested us to remove it. You do want to see where they were trained, what the problems were, all kind of stuff, so it doesn't make sense.
It was more that the system just couldn't handle it. So what's happened now is with the new technology that we have worked together through Breeze, the information can be entered, in fact, and it should be. You're absolutely right, it has to be there, but I would also urge that as part of the motion that we make a major push toward public information, make sure that people are aware that this is going on and that we need the information.
And I would just like to clarify, it will be information that we have to date of the application.
Right.
If a person changes postgraduate after they apply to us and we no longer, don't get that information, it will only be up through the point of what we've received in the application that gets posted.
But to clarify that further, that within the application process, our application should state that all information must be current and accurate.
Absolutely.
Printed on the application. Thank you.
Thank you. There's a motion on the table before the board takes action. Is there any public comment from those present? Seeing none. Any comment from the telephone?
We have no one in queue.
All those in favor of the motion?
Aye.
Opposed? Abstentions? Motion carries. Thank you. We'll move on to our next agenda item, item 17, discussion and consideration of proposed regulations, citations, and fines. Ms. Kirkmeyer.
Please turn to BRD 17-1 to 17-3 behind tab 17. The board's current regulations authorize a board official to issue a citation, a fine, and an order of abatement. The regulations also require the board official who issued the citation to perform certain functions, including holding an informal conference, authorizing an extension, etc. The regulations actually define board official as the chief, deputy chief, or supervising investigator 2 of the enforcement program of the board, or the chief of licensing. This is kind of one of those things that when we went through the process with SB 304, we didn't recognize that one of our regulations, once we transitioned our investigators over, was no longer going to be valid for us. So currently at this time, based on our current regulations, the individuals who could issue this citation are no longer employees of the medical board. So we need to move forward with regulations, and the regulation language is actually listed in your packet. We need to move forward with regulations to change this so the board can actually issue a citation. The chief of licensing can actually issue a citation, but the regulations are very clear that he can actually only issue it to an individual who has a delinquent, inactive, or restricted license, or to an individual who practices beyond their postgraduate training authorization of the 1 year or the 2 years. So what I'm requesting right now is that the board be able to move forward with a putting out the language, going through the regulatory process. However, one thing I'm asking a little bit different at this time on these regulations is, under normal circumstances for this particular board, we usually bring the regulatory hearing to the next board meeting. Because this is such a hot issue that we need to get this moving forward more quickly, I would actually like to ask the board to approve staff to hold the hearing outside of the board meeting as soon as the 45-day public comment period has hit. And if there are any negative comments, then we would bring those back to the board at that time at the October meeting, or possibly at a teleconference meeting that we would have prior to the October board meeting. So if I could have a motion to, and if you want, I can run through the language that's in the, okay, I definitely can.
so we have it just formal.
Yeah, so if you go to 17-2, the first change there is removing the names of specific positions and basically just have it the executive director or his or her designee. And then moving down, that's 1364.10. 1364.12 is actually removing board official who issued the citation. And the reason we're asking for this language to be changed is because what could happen is I may designate our enforcement program manager to issue the citation, but if that person leaves, then that means that when that individual wants to appeal their citation, I have nobody until that position's filled to actually continue that. And it's over the head of the physician. It's also an outstanding item for the board. So that's the change in 1364.12, as well as just a couple cleanup items. And then 1364.13, we want to remove that language for the chief of licensing in there, that they can only issue those citations, because again, it's going to be whoever the board official is. There won't be only a chief of licensing. In 1364.14, again, we're removing that, making it the board official who issued the citation to be the one that actually has to hold those informal conferences or extend items. And again, that goes back to the reason that, again, we don't want to be in this same situation. This is very similar to the way other boards are right now. They actually have executive director or his or her designee, as well as the requesting the hearing off cycle of a board meeting is actually how several other boards actually do their regulatory hearings. So I have a motion that's actually drafted into the item 17-1, if I could entertain that motion.
Well, and just to remind the members, there's two components to it. One is to direct staff to notice the amended regulatory language, as Ms. Kirkmeyer just went over, and hold a hearing as soon as possible after the 45-day comment period. And if no negative comments are received, this board would delegate staff to proceed with the rule-making process, so we can get it up and running as soon as possible, given its importance.
So moved.
The language that's stated in the memorandum on file. There's a motion and a second. Any discussion from the board? Questions? None? Any comments from the public, from those present? Any comments from the phone?
We do not.
Thank you. All those in favor?
Aye.
Aye.
Opposed? Abstentions? Motion carries. Thank you. We will now move on to item 18, discussion and consideration of proposed regulations updating the disciplinary guidelines, Title 16 CCR, Section 1361. Hello.
Hello.
Good morning.
In December 2011, Section 1361 containing the board's disciplinary guidelines was amended. Since that time, a number of statutory and program changes have occurred, which has prompted the need to amend the disciplinary guidelines to be consistent with current practices. Staff has identified a number of non-substantive changes that should be addressed in this regulatory proposal as well. I've included, my staff report provides the detailed description of the changes that are being proposed, including the language. So I'd like to just highlight some of the changes that are being proposed. The first change is in conditions 9, 10, and 11, which talk about the abstention from the use of drugs and alcohol and controlled substances, biological fluid testing. In this condition, the board is authorized to issue a cease practice order, but the requirement is that an accusation must be filed within 15 days or the cease practice order will be dissolved. This language was modeled after the timelines required for interim suspension orders. So the government code section that we used as our basis has been amended to extend the time frame for filing an accusation from 15 days to 30 days. So we'd like to amend the disciplinary guidelines to be consistent with this statute. The second change we're proposing is under condition 18, which is the clinical training program. The PACE program has revised and revamped their clinical assessment component, and we would like to modify our disciplinary guidelines to be consistent with their current program. We're asking for a change under condition 19, which describes or which authorizes the board to order an oral clinical examination of a physician going on probation. This condition, or this oral clinical examination, has not been really used very much, and it is a little more cumbersome to order and to fulfill. So we're asking to have that option be removed from the disciplinary guidelines. We've made a technical change under condition 25, which talks about the third-party chaperone. Currently, if a chaperone has to be identified within 30 days, however, if that chaperone leaves the physician's employ, the physician has 60 days to identify a substitute. And so we would like to reduce that timeline to 30 days to sort of enhance public protection. Let's see, condition 28 prohibits the physician from supervising physician assistants during their period of probation. It's been identified that advanced practice nurses perform a similar function and have a similar scope of practice. So we would like to add the restriction to, or to prohibit the physician on probation from supervising PAs and from supervising advanced practice nurses. And then we have some technical changes that we are proposing to the condition that describes what a physician under the non-practice while on probation condition. So when we combine those two conditions in the last edition, we omitted some language that we think is important to clarify what we expect a physician on probation residing in California but not practicing to comply with. I'm happy to answer any questions, and I'm requesting a motion to direct staff to notice the amended regulatory language and hold a hearing.
After the 45-day public comment period.
Yes, thank you.
Yes. Carrie?
Thank you. Yeah. There are a few additional changes that I want to have included in the motion for approval so that the initial language at least has the things that we caught to be correct in our first notice language. Yes. So generally, I want approval to make our capitalizations and our use of terms consistent throughout the paragraphs rather than going one by one. There's some places where we call it a clinical training program and some a clinical competence assessment program, and we need to evaluate whether what the proper term is and be consistent. Also, on item 28, we want to have the motion include approval for us to change the heading to supervision of physician assistants and advanced practice nurses. And again, the general authorization from the board to make the language consistent among the paragraphs. I think that'll give us the authorization we need to make the corrections in the initial noticed language.
Any additional comments, council? No, that's it.
That's it for me.
Thank you. We could entertain a motion now for the purposes of, or you could ask a question now, Dr. Lewis, if you wish.
Just point of information on number 28. Is the addition of the nurse practitioners consistent with the new statute? Is that why you're adding? Because nurse practitioners can operate in practice independently. So I just want to know is it consistent with the new statute, or are you just recommending adding it?
We're just recommending that it be added.
Because they can practice independently,
yes,
unlike physician assistants.
Yes.
I can answer that. Actually, many hospitals still have policies that CRNAs and nurse practitioners have to be under the supervision. It's a hospital privilege issue. It's not law. So hospitals can go beyond the law. So that's why that will affect that. My also thing is, I wanted to see what Dr. Bishop's opinion was, that advanced nurse practitioners probably include CRNAs. So is that seriously going to affect anesthesia departments?
The short answer is I'm not sure. I don't think so. I don't think it will deleteriously affect it, but.
Ms. Kirkmeyer?
And actually, I just wanted to let the members know that this recommendation to make this change on this specific one was actually from a board member during the panel meetings and discussion with, that if an individual can't actually supervise a physician assistant, they also shouldn't be supervising advanced practice nurses. So this actually came out of those discussions.
So we can have more discussion if the board desires, but for the purposes of moving things along, is there a motion to direct staff to notice the amended regulatory language with the comments made by council for consistency and title change and drafting issues, and to hold a hearing at the October 2014 board meeting after the 45-day public comment period? Is there such a motion? So moved by Dr. Kraus, seconded by Ms. Jaroslawski. We could have discussion again if there's any further questions or comments from the members. Ms. Jaroslawski?
I just want a point of clarification. I am not speaking any other than support of what's going on, but I just want to be clear that when we have a situation where a licensee is disciplined on probation and is in a solo practice in a situation, not in a hospital, but just solo practice, and is not able to supervise staff that is working there, does that affect the ability for consumers to have access to care? So what happens to a practice that has a disciplined physician who cannot supervise PAs and NPs? Is there a break in the ability to be served? So I just want to, do we have a window here of opportunity that is covered, that covers this?
I'll go to my left and then to my right. If that.
Okay.
Dr. Lewis?
Yeah, again, it's to my point of number 28 is what you're referencing, and your concern is actually my concern, is that this would potentially limit access to care. And so I want to be careful that 28 is actually, it's either in statute or it's a recommendation. So I'm concerned about that also.
I mean, if it's a tool for the disciplinary unit to impose, or is it a law? And that's my concern.
Doctor?
Several small 30, 40, 50 bed hospitals have one anesthesiologist and couple nurse anesthetists. So that could affect, it depends upon their bylaws and their rules and regs. So this is a serious also access issue. So that's why we got to be very careful when you include everyone, including CRNAs, nurse practitioners, and everything else. So that's why I just want us to be aware of what the consequences could be for the access to care for the consumers, especially in the rural areas. I'm not worried about large cities like LA or anything else, but it is the smaller areas which I do get concerned.
I'm suggesting that hospitals have coverage. I'm suggesting that individual medical offices might not. So that was my concern. I think the hospital, they can put other people in. So I just want to make sure that as far as access to care goes, that there's some discretion left to staff or not. Then my question is it?
Yeah, we always have, well, if it's a stipulation, we always have the ability under mitigating circumstances to say we will lift this term out of the probation. We've done that with the PAs. I think this goes to a consumer protection issue as to, would you want a physician who has been, let's say maybe they were in trouble for a lack of supervision, and that's what we're actually disciplining them for. Would you want them providing supervision to anyone, whether it was a PA, a nurse practitioner, or a CRNA? And that's where it goes back to, is the consumer protection issue. Somebody that's been put on probation and you're already saying that you don't want them to supervise a physician assistant, I don't know that you would want them to supervise a nurse practitioner or a CRNA either.
That's the thinking.
Yeah,
Dr.
I
Yip?
agree with what Kim say. It always individualized when it comes to disciplinary hearing. So even the language in, we can still modify this.
Colleagues, are there any additional comments, questions of staff? Thank you. This is very informative. Are there comments from the public, from those present? Seeing none, any comments from the, oh, we do have one. Ms. Castro?
Good morning, everybody. This is directed to Ms. Webb. Just wanted to point out that possibly on condition number 10, our office staff would recommend that the first line, respondent shall abstain completely from the use of products or beverages containing alcohol. Consistent with your prior recommendation to keep everything sort of consistent with each other, the prior term and condition on number 9 says personal use. I would suggest that the word use be expanded somewhat so that doctors that enter into probation supervised by the medical board are abundantly aware that use means incidental or purposeful. So if grandma made that rum cake, you ought to be rude if you're on probation, if it contains alcohol or whatever, or vanilla. These tests tend to be very sensitive and can, Purell, has alcohol, and we hear this somewhat. And so I think it would be a good thing to expand upon, Ms. Webb. And that's one of my comments. Thank you so much.
Thank you, Ms. Castro. Are there any additional comments from the public? Any comments from the telephone?
We have no comments in queue.
A point of clarification from Ms.
And I'm sorry, I should have brought this up earlier. One point I did want to point out is that this section that is going to have to be changed to incorporate the disciplinary guidelines, section 1361. This is also the section that's currently involved in our regulation to implement SB 1441, and we cannot have two regulations on the same section at the same time. So we will have to wait for the one regulation to go through before we can actually notice this. So depending on how long that takes through the process, it might not be until after that. So we have in here that we would bring it back at October, but that may not be the case. I just wanted to let members know in case we do run into that kind of snafu. So we'll let you know.
Okay, thank you. All those in favor of the motion?
Aye. Aye.
Opposed? Abstentions? Motion carries. Thank you. We'll now move on to item 19, update on transition of staff to the Department of Consumer Affairs. Deputy Director Gomez. Good morning.
Good morning. Good morning, Mr. President and members of the Medical Board of California. My name is Michael Gomez. I'm Deputy Director for the Division of Investigation and Enforcement Programs for the Department of Consumer Affairs. It is my pleasure to be here this morning to tell you that we've had success in the transition in implementing SB 304. We, as many of you may or may not know, that we had a swearing-in ceremony on June 30th and July 1st. And to Dr. Ganadev, I have to apologize to you. The venue for Riverside that I originally said was going to happen in May, it just became a location that was too crowded, and we couldn't. I don't think the fire marshal wanted us to have that many people there, so we moved that swearing-in ceremony to the Police Academy at Golden West College. So my apologies, sir. In that. Prior to July 1, I want to give you some background summary. Prior to July 1 and beginning in October of last year, we provided this board with a transition plan, a high-level transition plan that had many components and milestones related to the accomplishments of not just discussions, but the implementation of our budgets and staffing, the complaint process, if you will, the amendments to the facility usage, et cetera, all the administrative stuff that goes along with this kind of administrative procedure. And I have to tell you, it's been a lot of work, but the the work that we've been doing along with Kim Kirkmeyer and Renee Threadgill and Laura Sweet has been not only beneficial for me in understanding the culture of the Medical Board of California's work, but also I'm now becoming immersed, if you will, in the work of what the Medical Board and its investigators, our investigators, are doing under vertical enforcement as well. But that said, is that with respect to movements and relocation, there hasn't been any relocation of the district office personnel at all. No one has been impacted by any moves or any relocations in that respect. The only unit that has been relocated to the Division of Investigation headquarters in Sacramento has been the Office of Standards and Training, which impacted approximately 7 people, because I think there were 2 vacancies as well. And so Renee Threadgill, Chief Threadgill, is actually on the 3rd floor down the hall from me, and is my teacher and mentor in understanding the nuances, if you will, of the complaint and investigation practices and analysis that goes into the medical board complaints and the evidence that's needed for that. We finalized, Dr. Lewis. I know you're interested in the labor issues. We finalized our meet and confer with all the unions last month, and it was a very successful meeting. There are some minor technical issues that need to be worked out, but it's nothing major, and we've been very, very open with the labor unions in terms of the issues that they may have had or concerned about. We also finalized and had and I saw that in your enforcement summary yesterday, that it reported that we did have a teleconference, a statewide video conferencing with all the investigators and all the staffs that were impacted by SB 304 to answer questions, any questions they had regarding the transition and the operations and whether I was going to be demoted or am I going to lose my job, et cetera, et cetera. So we pretty much dealt with all of those questions in settling everybody's nerves, and I again am happy to report this transition actually has gone very well. It really has, and it's a lot of it related again to the work of the medical board staff and the DCA staff and the support staff and the counsel that I received from Renee and Kim on this transition. On post July 1st, and just to kind of put it into context, I've only had the unit for 26 days. So again, I'm immersing myself in the operations of the Medical Board of California and its investigative process and vertical enforcement as well. So I'm learning, as well as looking at the efficiencies or inconsistencies that we can improve on and work with Kim in terms of, am I looking at this right? And to use Kim's words, I'm going to always echo this to you, Kim, because you've told me this early on that I haven't lived it, but now I'm living it. And it's a lot of work, but I really do appreciate and understand the work that our investigators and the commitment that they have to the work in protecting patients and consumers of California. They are dedicated people, highly trained. The last Monday, Renee and I and my deputy chiefs on the investigation and enforcement side of the Division of Investigation had a leadership meeting with all the leadership of the division to start having some Q&A, if you will, in terms of the differences and what resources we have to our availability and the processes in terms of mailing and all the questions that come up with field office work and the pursuit of our investigations for protection of the consumers. And again, we will have another meeting on August 5th with all the supervisors of the Health Quality Investigations Unit to begin discussions on looking at what works and what improvements we can pursue to better the investigative practices and to better protect consumers in our joint mission with the medical board. And we have continued to meet with the investigators of the Health Quality Investigations Unit, and the transition in and of itself, although complete, I think the continued communication with our staffs is so important that to make sure that we clarify and that they are sound in terms of what their roles and responsibilities are as law enforcement officers within the Division of Investigation. We still have some outstanding matters which need to be addressed, but I'm confident that, and optimistic actually, that we will have better enforcement and investigative time cycles in the coming year. And my commitment is to make sure that that in the meantime, in the interim, while I'm learning, is that we don't have further delays. We look at what efficiencies we can implement, working with the Medical Board of California and working with the Attorney General's office in how we can better protect and better look at and really self-reflect on the business that we do as consumer protection agents. Thanks goes to the board for being patient through this whole process and understanding. And I know, Mr. Yaroslavsky, you've been watching me pretty closely in everything I've been doing, so I'm kidding. But
I would hope that everybody sitting around this horseshoe is watching very carefully, as well as everybody on that out there in the real world.
Right, and I think in the last one, or maybe it wasn't the last minute, but I really asked you to hold me accountable in what we're doing with the transition and what our work is and what our costs are and what our cycle times are and what we're doing in terms of making this transition not only working for our staffs, but that it's better for the consumers and patient protection as well. And then lastly, I just want to tell everyone, Kim, thank you very much for all of your help. You're kind of a subject matter expert for me in this transition, and to Renee Threadgill, Chief Threadgill, who's working actually with the retirement of Laura Sweet, working as my deputy chief over at HQIU as well, and she's been a great resource to me and to all of you who have been so thankful for. I've been so thankful for your help and patience, and so that's the brief update. Please feel free to ask me any questions if you have any.
Questions from the members?
Oh, of course.
Ms. Yaroslavsky?
I'm accountable, I know.
I need to wear the hat, I guess, now. Nobody else is. I just want to know how down the road, if you could give us some ideas, what are the benchmarks that we could look to hold that there are improvements and changes, and how are we going to measure this success?
Well, I think there's a couple things we want to look at. We want to look at the benchmark that I think you, Kim, may have reported some figures in one of your reports. But I have already established. Go ahead.
Oh, I was just going to say that until we have Breeze, we aren't reporting the timelines at this under the reports out of Breeze. We aren't reporting those timelines.
Right, and so the board members understand that internally, I'm working with Renee and the staff and making sure that our case management information milestones, if you will, the cycle times, that we do have a benchmark as of June 30th or July 1st. And that's the basis from which we're trying to either decrease certain timelines or make some efficiencies in the quality of the investigation as well, working with the AG's office. So we know that report that I can give you at some junctures, that where we were on July 1st and where we are on a specified date, that we're showing some improvement. But more importantly, from the executive director, am I servicing the client as well? That's the other side of it. So there are metrics in place to do that.
And I'd also like to, what I heard also is that everyone's getting along and everyone's working together, and it's kind of a smooth transition, and you guys are meeting all together with everybody, and so far so good?
In the division side, I would say so. We're still working with the Attorney General's office. Remember, I've only had him for 26 days, so I'm seeing things that I think we could improve on, but that's a discussion that I think Gloria and I need to have in terms of how we can make things better.
So that Gloria and I are going to have is going to happen?
Yes, it is.
No, I just want,
it
the
is.
nuances of language here is very important, and I just want you to realize that, my attentiveness to this is in order to better ensure that the needs of the public are being met.
I totally understand.
And they're not going to be met if I constantly hear that it's going to happen and it hasn't happened yet, so. That's what I'm looking to hear. That
Chief Deputy Director Tracy Ryan is in charge and the lead in the coordination of those meetings.
Okay. I look forward to your reports every one of our meetings.
I'm here.
There'll be more. Doctor, do you have a question?
Yeah, thank you, Mr. Gomez.
I should have called you first, huh?
No, it's okay. Thanks for coming, and even though I'm off the enforcement committee, I will be still watching you.
Okay.
So, just want to, first thing is that even though the investigative staff are not getting paychecks from medical board, that money is coming from the medical board, so they are part of our family. I just want to make sure that you're all aware of, and we are solidly behind them. We do have to work on, I think, when our executive committee has a retreat, or we have to come up with how to shorten the timelines. Really, I mean, and then give you that and expect our investigative side to really perform that, what we really want, what public really want. I think that's what we'll be doing. You'll be integral part of it, so that we all can work together to really get these timelines shorter.
I'm your partner in that endeavor, and I hope that you will seek my attendance as well, and advice in terms of what we see and what I don't see, what you see.
Thank you.
You're welcome.
Are there any additional comments or questions from members of this board? Thank you for that report.
You're welcome.
Very informative. We appreciate the ongoing dialogue.
Thank you.
Are there any comments from the public? Seeing none, any comments from the telephone?
We have no one in queue.
Thank you. With that, we'll move on to agenda item 20, Vertical Enforcement Program Report. Ms. Castro, Department of Justice. Good morning.
Good morning. First off, congratulations to you, Mr. President. I know that this board is in excellent hands, especially since Sharon Levine, the departing president, really set a very good tone for the board and navigated some troubled waters during the Sunset Review hearing. And I'm really looking forward to working under your leadership as well. And I must say that I continued, obviously, to meet all the time with Ms. Kirchmeier. Ms. Kirchmeier and I enjoy a very collegial relationship, and Ms. Webb hears from me very often with respect to ideas and efficiencies and things that impact the boots on the ground. Our attorneys are the ones that discuss your disciplinary guidelines with them, explain to their attorneys exactly what it means to enter into probation with the board, such that it won't be a plan to fail, but rather a plan to rehabilitate, which is your mission, and to bring that doctor back into the fold so that he and she can practice medicine, which is what their life calling was. And so today what I'm going to do is essentially go ahead and expand upon SB 304. And my main message is that everything is fine and will continue to fulfill all of your policy goals and intentions. And the transition has been smooth. I agree with Mr. Gomez, and we'll continue on the trajectory that it has to go. So I'll give you some of my remarks. I'll do my staffing update. I'll tell you about a case that I think you should know about involving cures. So under the vertical enforcement model that was in effect from 2006 to July 1st, 2014, Senate Bill 231 established the course for those investigations. The Health Quality Enforcement section enjoyed a very direct line of communication with the executive directors and with Ms. Kirchmeier, and therefore you as the client as well, through the NBC enforcement chain of command. And in short, the investigators were the employees of the board, and they reported ultimately to the executive director of the board and to you. The investigators, well, basically, when the Attorney General's office directed these investigations pursuant to Senate Bill 231, we were directly involved with the investigative employees in the board's chain of command. The Attorney General's office has been exercising its authority to direct investigations established by Senate Bill 231 for the past 8.5 years. So we have the experience and depth of knowledge with having worked with you, listening to you over the last 8.5 years, and changing course with policies and reactions according to what is needed. With the passage of Senate Bill 231, the legislature significantly expanded the statutory responsibilities of the Health Quality Enforcement section by adding to its administrative prosecution responsibilities. We were given the duty to direct the investigations that led to the prosecution of administrative cases against physicians and surgeons. And in enacting Senate Bill 231 and creating the vertical enforcement model, the legislature amended portions of the government code that directly govern the statutory duties of the Attorney General and added responsibilities to them and that office and consequently to us. SB 231 also reorganized the operation of the health quality enforcement section itself. So we've gone through some transition ourselves already, and I know that we can weather whatever we need to do to meet our obligations with the Health Quality Investigation Unit. These were not amendments specifically to the State Medical Practices Act, which the Medical Board is charged with enforcing, but rather new statutory responsibilities of the Attorney General of the State of California, which she obviously takes extremely seriously. The Attorney General, working closely with you and our clients and its executive officers, have been executing these duties for the past 8.5 years, like I said. And our view of how these responsibilities are imposed on us by the government code has been reflected in various iterations of vertical enforcement manuals since 2006, January 1. And we have a long history with having to try things out, scratch them, redo them, etc. And I am open to whatever process is necessary to find efficiencies, scrub the process, and figure out how we can save days. In the subsequent iteration of the joint manual, the last one, the one published in July of 2011, we've been working under that for a good 4 years. At the request of the board, our client, following the issuance of the first VE manual, we've continued to make sure that the main purpose of the manuals set forth the procedures by which investigations will be directed by the assigned Deputy Attorney General in order to produce the evidence needed by the Attorney General's office to effectuate the Attorney General's responsibility to advise you, the board, on legal matters, including principally whether a formal accusation should be filed against a physician and surgeon. That is a very, very important obligation. The Attorney General's contemporaneous and consistent administrative construction of Government Code Sections 12529, 12529.5, and 12529.6, like I said, it has been in the past manuals and will be established and has been established as of July 1st, and in the latest version of the Vertical Enforcement Manual, which is the 4th edition. And I understand Ms. Kirchmeier has provided that to you for your review. And that manual has been also provided to the Health Quality Investigation Unit and DCA. So in essence, the joint manual continues to take forth prior relationships between the Attorney General, except that now the names have been changed to accommodate for the changes that SB 304 put into place. Notwithstanding this change, these investigations are still subject to vertical enforcement and continue to be directed by our office. And like I said, unlike SB 231, the investigation management now doesn't have a direct chain of command back to the medical board, as these investigators now work for DCA. However, the executive director will obviously continue to determine what she wants to send to the Health Quality Investigation Unit, and as such will continue to be very responsive to what it is that you want to be investigated by HQAU. And she too is finding efficiencies in the process, and we fully support her in every regard. In addition to that, Ms. Kirchmeier has the obligation to review final investigation reports on closed investigation. She has the oversight review. And again, we are going to be very involved with that process with you, Ms. Kirchmeier. And I hope that you continue to look to us, as you do now, for any background on legal justifications, evidentiary issues, and medical expert opinions that may have not created the filing that the public sometimes expects, but that is a fair and equitable resolution that should carry your name as the board. At the same time, the Attorney General's office has provided, like I said, the Vertical Enforcement Manual that has been in effect as of July 1st, given the fact that the prior version is now obsolete. And it will reflect, and it reflects, as you will see when you review it, that the investigations will continue to be directed by the Attorney General's office to fulfill her statutory responsibilities to provide legal advice to the board. In addition, the Health Quality Investigation Unit has been informed as to how cases should be presented to HQE to allow for efficient handling and receipt of cases at the Attorney General's office. We too took this opportunity, as Ms. Kirchmeier knows, to find efficiencies in our own process such that there aren't unnecessary billings and things are very efficient. And we run a very, very tight ship. And as you all are aware, I've only been there about a year and 3 months. But we've done a lot in the last year and 3 months such that we were very prepared for this change. We memorialized in case transmittal guidelines, which we provided to your chief counsels at the DCA, as well as every single one of our clients, including the medical board. These guidelines, coupled with the new procedures set forth in the manual, aim to ensure that these cases can be efficiently processed between offices. That matters such as scheduling of physician interviews, expert selection, expert report review, and our consideration for acceptance for prosecution proceeds effectively and efficiently for the benefit of the investigations and their resolution. The authority of the Attorney General's office to decide what cases she will accept for prosecution continues as before, as does the executive officer's ability to thereafter decide what she will file as a disciplinary action on behalf of you, the board. In other words, the Attorney General makes the legal determinations regarding whether a case meets an evidentiary standards, and the executive officer continues to decide what cases she will sign on your behalf. And that means that she decides what will be pursued by you, the board, as a disciplinary matter. This procedure remains unchanged and undisturbed, and your policies and filing postures will continue as before. Importantly, SB 304 did not dilute the medical board's ability to function as needed in fulfilling its statutory charges to enforce the Medical Practices Act. While the medical board shares the general purpose of public protection served by all agencies at the Department of Consumer Affairs, the legislature has specifically declared that the protection of the public is your highest priority. And the legislature has also further declared that where rehabilitation and protection are inconsistent, protection shall be paramount. As your legal counsel, in judicial and administrative proceedings concerning disciplinary matters against licensees, as well as your attorneys charged with directing your investigations, we take our obligations exceedingly seriously. We are your partners in making sure that you ensure the quality and safety of medical care in California. We are proud to be your attorneys. I think you hear that quite often when I come up here. We work diligently to protect healthcare consumers, and we believe wholeheartedly in your mission to set the highest standards for your dignified profession. This board, as noted by the legislature in SB 231 back in 2005, performs a critical function of state government. And it was because of this critical importance in your functions, in your public health and safety functions, I should say, and coupled with the complexity of cases involving alleged misconduct by physicians and surgeons, and the evidentiary burdens in the board's disciplinary cases, that the legislature found and declared that using a vertical enforcement and prosecution model for those investigations is in the best interest of the people of the state of California. This enactment followed one of the recommendations in the final report of the Medical Board Enforcement Program Monitor, and this report was published in 2005, 9 years ago. Now, I want to stress that Senate Bill 304 did not affect anything in the team concept and how we manage our cases. The team concept is at the root of this, and it needs to work that way. And we all have to be in it for the team and for what the ultimate purpose of these investigations are. The Department of Investigations HKU staff will be engaged in a team effort to be responsible for obtaining the evidence needed for the Attorney General's office to make proper legal determinations and to provide legal advice to the executive officer on investigation outcomes and filing decisions. The Attorney General and the HQIU are both committed to complete these investigations as efficiently as possible. And the goal to find improved avenues to complete investigations as efficiently as possible is a shared goal. I have shared my ideas with HQIU and look forward to continue that conversation. I've met with Mr. Gomez repeatedly over the last, well, since about November and December, and have been working on dispute resolutions already and different cases that have come up. And even though he's been on the job for 26 days, we speak every couple of days about cases. And we also have to continue a conversation about the larger policy interests. SB 304 did not change the fact that investigators undertake the investigative steps necessary to obtain evidence in investigations. Again, SB 304 did not change any evidentiary sufficiency in a legal determination made by our office. And SB 304 did not change the Attorney General's role with respect to investigatory staff, which is now housed at DCA. SB 304 did not change the fact that our legal staff is supervised by their SDAGs, myself, my chief, and ultimately the Attorney General. So in many ways, most things continue as they were before. The Attorney General's direction authority continues to be connected to its three most important functions as your legal counsel in your board and your investigations, and as counsel subsequently in anything we file before the Office of Administrative Hearings and defend in Superior Court and Courts of Appeals, etc. The efficient operations of the Health Quality Investigation Unit is a crucial component of everything that we do, and evidence collection is key. The Attorney General's ability to make its legal recommendations rest on her having the required evidence collected in the investigations and proper steps being taken in procuring this information, such as with service of subpoenas for medical records, properly questioning subject physicians during investigation, and obtaining reviews from qualified medical experts. We all need all these components to work efficiently so that the Attorney General can advise the medical board on legal issues developed in your investigations. As a reminder, our legal advice relates specifically to the three most important things: whether you should file a formal accusation, interim suspension order, mental examination order, Penal Code Section 23, bail restriction order in criminal cases against physicians. Number two, we continue to give you legal advice on whether an investigation on a physician should be closed due to a lack of evidence required to meet the applicable burden of proof. And number three, whether to take other appropriate legal actions, such as issuing a public letter of reprimand prior to filing an accusation, issuing citations and fines, or even yet referring these matters to an outside agency, including criminal authorities. The above functions, of course, are dependent on the procurement of legally defensible evidence in each and every one of these investigations by the Health Quality Investigation Unit. Your cases live and die based on the quality of the investigations. Due to the recognized property interests of physicians and surgeons and their licenses, as you are all aware, the standard of proof in an administrative hearing seeking to suspend or revoke such a license calls for clear and convincing evidence. Clear and convincing evidence requires a finding of high probability, evidence so clear as to leave no substantial doubt, evidence sufficiently strong to command the unhesitating assent of every reasonable mind. Thus, again, the weight and quality of this documentary and testimonial evidence procured in your investigations is assessed against this high standard and determines our ability to meet your goals of protection in every single case. In addition, our staff is trained to be able to identify any evolving legal issues that need to be brought to the attention of Ms. Webb and the executive officer, Ms. Kirchmeier. And again, this is something that is a day-to-day basis. If a new case comes out or if there's a posture that you need to be aware of, we always try to find fixes and whatever we can to communicate them back to you. In conclusion, as the attorneys for the medical board and the executive officer, we hold all of these obligations in the highest regard and will continue to uphold all of our ethical obligations to you. And I want to reassure you, as does the Attorney General, that your cases continue to be in good hands. And in that regard, like I said, the Attorney General went ahead and put in a Vertical Enforcement Manual, 4th edition, on July 1st, 2014. We needed to assure the continuation of the vertical enforcement model after July 1st, 2014. And the AGO, the Attorney General's Office, will meet with Department of Consumer Affairs to discuss the possibility of a joint manual. And the Attorney General will work with the Department of Consumer Affairs to identify and create efficiencies in the workflow, especially with regard to evidence sharing between our agencies. And we will report back to you, obviously, in October 2014 with a status of those conversations.
Zach.
So now I'll continue with our staffing report. We've had 2 new DAGs join our section. Carolyn Westfall in San Diego has joined us from the San Diego City Attorney's Office, And Christine Sen has joined us as a deputy in the Los Angeles office, coming from a major law firm. I'd like to report also on the outcome of the Lewis case, Lewis versus Superior Court. A decision was reached by the Court of Appeal on May 29, 2014. Dr. Lewis had filed a petition for writ of mandate with the Court of Appeal, which sought relief from an order upholding your disciplinary decision. One of the issues that had been raised in that appeal, however, involved cures and whether the board could obtain data from cures during a disciplinary investigation of the physician without obtaining a prior warrant or administrative subpoena demonstrating good cause. We won for you. The Court of Appeal ruled that you, the board, can access cures during the course of disciplinary investigation and that it did not constitute a serious invasion of the patient's right to informational privacy. And further, that there were two very important state interests weighing in favor of the board. Number one, controlling the diversion and abuse of controlled substances, and number two, exercising its regulatory power to protect the public against incompetent, impaired, or negligent physicians. Further, the appeals court also held that to impose a good cause requirement before accessing cures data would necessarily involve litigating the privacy issue in advance, and this would be in an investigation. And this delay would defeat the legislative purpose of cures, which is to allow doctors to instantly look up a new patient's controlled substance history and to determine whether a patient legitimately needs pain medication or is doctor shopping. Also, real-time access to cures protects patients from incompetent and unprofessional doctors. Finally, the court also found that the board's access to cures should not be limited at all by the nature of the complaint lodged against the licensee and physician. This is very important because once we do have a physician in an investigation, this is considered part of the investigation, just looking up cures as well. So from the patient's perspective, though, the privacy interest in their controlled substances prescription records is no different if the board is investigating unprofessional conduct in their care and treatment or unprofessional conduct due to an alleged improper prescription practice. So Lewis is important because the case arose after administrative action by you, after we filed an accusation. And the Chiarotino case, which I reported on last in May, had to do with the board's ability to look up cures in an investigation. So I want you to know that the Court of Appeal has said that you can look it up in investigations, like in Chiarotino, and can also look up cures in an administrative action that had nothing to do with prescribing practices. And so with that, I have concluded my remarks.
Thank you, Ms. Castro,
Thank you.
For that report. And I just want to add to the board's sentiment. Thank you for your leadership. It's been a real joy working with you, and we look forward to this continued relationship. And then please extend our appreciation and thanks to your staff as well.
We will.
We are greatly appreciative. Are there comments or questions from board members? Dr. Lewis?
I have, thank you for that report. It was very, very educational and informative. I have two questions. I'm going to ask both of them. And if you could, on the first question, you mentioned a lot of efficiencies. You also mentioned the word inefficiencies. You recognize inefficiencies. So if you could tell us what you see the big inefficiencies are in your organization and how they might impact what the medical board does. So that's my first question.
Mm-hmm.
And I'll ask you the second question. Do you occasionally, and this may be a rhetorical question, sit down with the Office of Administrative Hearings and have frequent or at least some type of discussions with them for feedback, between both parties? So if you could let us know about those interactions, I would appreciate that.
Yes, one thing I'm very looking forward to continuing the conversation about would be the development of a cloud. It's mentioned in your meeting minutes. We didn't talk about it, but I've met with Mr. Kodani and with Ms. Ryan on several occasions, along with a team from my office involving the case management section. And you heard me say the word evidence like a million times in my remarks. And that is the most important thing that we need to get, and quickly, without delay. And so I'm excited to tell you that the Department of Consumer Affairs is open-minded and listening, as is Ms. Kirchmeier, on how to efficiently transfer evidence between staffs that are not co-located. I don't think the vertical enforcement model requires necessarily for people to be co-located if there is a very efficient transfer of information back and forth between offices. And that's one thing I need to work on. I don't want things mailed. I want things instantly sent to us, and with the proper encryption and the proper protections, obviously, for patient privacy, but one that affords the attorney a real-time access to the evidence that they need in order to prepare for a subject interview, to properly assess the quality of experts that are going to review the case. And so I have to say that that has been one of the struggles in trying to put into effect and this vertical enforcement investigation model, in that when the attorney requests the information, it needs to be sent over pretty much right away. And there has, I think that already there's been movement to try to unlock a lot more of the capabilities of hardware to be able to send massive PDFs over to our office so we can review thousands of pages of medical records. These are not small cases. These are huge cases. In my first meeting with Mr. Gomez in November, I actually showed him a case from nose to tail. And I chose on purpose one that showed both aspects of it, an investigation and an administrative case, and the filed case and the decision in order. And that was a very small case. But I did stress to him that these are boxes and boxes of information. As you know, I mean, we're all going to get away from paper, and that's one of the issues that I'm very excited about with the advent of electronic medical records. I think that the transfer of information between offices will be a lot better. So that's one efficiency. Obviously, our staff is trained to identify early case closures. Each day that a physician is mired in an investigation without needing to be is one day that physician and his family and his patients are not getting to see the physician. So that's one efficiency that I think we will work on to make sure and identify early case closures. And we all have scarce staff, quite frankly. Everybody's overworked. And if it wasn't for the passion, and many people digging deep into that passion bucket on a repeated basis and loving what they do, I don't know what we would, your cases would just not move any quicker. But we're very lucky to have very fantastic staff on both ends, your investigators, your former investigators, and our current staff, obviously. And so we want to close cases early that need to be closed and identify cases that meet your high priority. It's in your statute. It's very clear what you need to focus on as a high priority case. And we want to focus those resources on those cases, the ISOs, the PC-23s, the mentally ill and impaired physicians, the things that really scare the public, okay? And so that's my remarks to your first question, Dr. Lewis. The second question, the Office of Administrative Hearings. I meet on a regular basis with Don Chang and Ms. Johnson and share with them some of our issues with the Office of Administrative Hearings and some efficiencies that we could find together. We meet on a frequent basis with Office of Administrative Hearings with the assistance of your DCA counsel. I apprise Ms. Kirchmeier all the time of different things that she should know about. For example, which offices are setting hearings and when and for how long. And one thing that I think that is very key to understanding our cases is that once we file them, you, the medical board, don't control many things. You don't control who the doctor hires as an attorney or whether the doctor hires an attorney. You don't control how much time the doctor feels that he or she needs to defend themselves. They're in the fight of their life many times, and I understand that. That's why we take everything so seriously. And so that's one factor that I think we need to be reminded of, is that if they need time to protect their property interest in their license, they will be afforded every opportunity by Office of Administrative Hearings to do so. It is not the real posture of our office to allow continuances to go forward on your behalf unless there is a real need for a continuance to occur. But we can't, you, the board, can't control whether the Office of Administrative Hearings allows the continuance. You can't control whether one of their experts quits and they need to find a new one. So there's, so Office of Administrative Hearings is a huge issue that we always look at.
I'm going to answer just a little different way, a little bit different nuance to it. The feedback after case is completed, that kind of discussion between the two parties, does that take place as a wrap-up?
Probably not, and I'm going to tell you why, because after the fact, we need to continue working with the Office of Administrative Hearings, and each case is different. So what the judge saw in terms of credibility or the evidence in front of him or her, it's going to change. So even though we're producing these cases, every single one falls and rises on their own merit. So specifically, do we have a postmortem, so to speak, on a case and the outcome? However, Ms. Kirchmeier and I consistently review these decisions and orders. I do try to make sure that our staff is being responsive to what is said in the decisions and orders, such that if we need to if I can fix something in my office in terms of how we present evidence or what went wrong, I do that myself. I don't go back to OAH. And again, it's a touchy subject because I don't want to engage in any ex parte communications with the judge, especially since I don't know if the doctor is going to file a writ on that case. I just really, it's a conversation that happens on a big capital policy procedures, but not, granular.
Right.
Thank you, Ms. Castro.
Okay.
Thank you.
Are there any additional questions or comments from the board?
Yeah,
Doctor?
just Ms. Castro, we truly appreciate you being, I think, beyond what we expected to really come and update us. So you are going to be the integral part of the triangle with the medical board, DCA, and AG's office to really streamline the process. We are really trying to see how we can streamline the disciplinary process where we can cut down the timelines and when we need the ISOs, I know Office of the Administrative Justices is totally different, but we somehow or other, public has this feeling that we are too slow, take too long, so we need to streamline that, and thank you for your efforts.
Thank you, Dr. Gonadev. And the first thing I do every morning when I wake up is review all of my Google News alerts for the medical board. Find out what doctor that is and what DAG is on that case. And my staff hears from me first thing in the morning. I also review everything to make sure that the medical board's aware of the latest sexual offending, child pornography, possessing doctor, just to make sure everybody's on the same page. So I must say that as your attorney, I'm always cognizant of how you are criticized or not. I wish your efforts were highlighted a lot more, but you do a lot of fabulous work. Unfortunately, there are cases that come to the attention of the public, but whenever you're there, we're there with you, and so is Ms. Kirchmeier, and so will Mr. Gomez, and so will the investigator. We all look at that, and we all feel it with you. And that's why I think you're very well respected. You two are public servants like we are, and you two are in it for the good fight. So, and we all wear the white hats. So.
Thank you.
All right, thank
Brief
you.
comments?
Brief comment before you leave. I want to as well thank you. And going back to your bucket description of commitment from your staff and from the investigative staff, on a go-forward basis, this collegial relationship is what's going to make and break the situation. And reading through the manual, I just want to suggest that there's a lot of opportunity for collegiality in the manual from what I read, but there was also a lot of the word direct processes. So I just want you to be cognizant of the fact that when I read it, I saw the direct, I also saw the collegiality opportunities, and hopefully they're coming together more under collegiality versus direction being given by your office.
Right. And Mr. Gomez is aware that I'm going to continue to allow him to supervise his staff as he needs to with respect to their investigative techniques and different aspects of it. We're not the cops. And ultimately, he also understands that the legal advice has to be consistent. I think that's one thing that maybe I can respond to Dr. Lewis, is that one of the efficiencies that I've worked on in the last year and 3 months is to make sure that every single office and every single DAG is on the same page with how we actually execute this important responsibility. So with that in mind, please know that if it reads that way, it has to read that way to my staff as well. So it is a manual, and I want them to direct the investigations. I want them to be engaged as they are, and I want them to continue to take this in very high regard. So because it's an Attorney General responsibility, yeah.
I appreciate that. We
All right.
appreciate that. Are there any comments from the public? Mr. Gomez?
Mr. President, members of the Medical Board of California, I just wanted to clarify a couple things that the Attorney General's office has informed you of. The publication and the imposition of a 2014 vertical enforcement manual has not happened on the DCA side as yet. As I've told you, I've only had them 26 days, and I've had a team of Laura Sweet, a deputy chief, and also a supervising investigator too, looking at our current practices to make sure whatever we comport to is consistent with the efficiencies and the collaboration, understanding directness, understanding professionalism, understanding teamwork, understanding a host of what other best practices are in the state of California and local governments and the district attorney's offices that I'm aware of. So we have not imposed that manual on our staff as yet. The second thing is, it's my understanding, and earlier on when you asked Madam Yaroslavsky about when, again, my chief deputy director, Tracy Ryan, is coordinating a meeting with Gloria Castro and her staff to relook, if you will, at what it is we're doing and how do we make this better. That the directness and the roles of the investigator, the roles of the prosecutor, the roles, and whether it's training or whether it's in a true partnership. I mean, for us to say team, it really has to mean team. And Mr. President, working in local government, in police departments and sheriff's departments, we're very attuned to the models that work best, and not all investigators are employed by district attorney's office or a city attorney's offices, but we work closely together because we are part of a true profession, and it's called public safety. And my commitment to Gloria is that we will continue to work together. We just have new leadership, pure and simple.
Thank you.
You're
for
welcome.
that. Appreciate it. Is there additional public comment? Seeing none, are there any comments from the telephone?
There are no comments on the phone.
Colleagues, I promise a brief break, but we'll just get through a couple more agenda items. Then we'll have a stretch break, if that's okay. But before we go to the next agenda item, which is agenda item 21, a point of privilege from our executive director.
I would actually just like to ask Laura Sweet and Susan Cady to stand. These two individuals, unfortunately, to our great loss, have notified us that they are going to be retiring. Laura is actually out on vacation until October 8th, but October 8th is her retirement date, and Susan's date is supposed to be October. I'm trying to hold on to both of them as long as we can, as I'm sure Mr. Gomez is to Laura. But I just want to recognize these two individuals. They've both been at the board a very long time, and to lose them is going to be to lose a huge wealth of information, knowledge base, just great employees and employees that you can always rely on and count on to get an answer. I know I've had so many staff come in and say, what are we going to do when Susan leaves? What are we going to do when Laura leaves? So we're all feeling the pain of retirees. We've had a lot of retirements. I have a couple more that are coming that will hit us greatly. But these two employees, I would be remiss in not recognizing them. They both come before the board frequently. You know what a wealth of information these individuals have, and what a great asset they are to the board. And I think we need to thank them publicly for their service to the board.
Thank you both. We're so appreciative. On to the agenda item 21, update on the prescribing task force. Dr. Bishop and Ms. Yaroslawski.
I believe Ms. Yaroslawski's pointing at me, so I'll be glad to
Okay.
do that.
I'll check.
Her mouth is tired today. Very good. On June 19.
I warn you, doctor.
2014.
As long as you didn't say my brain is tired, I guess it's okay.
That was you.
That wasn't intended to be a negative, Barbara. On June 19, 2014, the Prescribing Task Force held a meeting with all interested parties. Prior to this meeting, board staff had drafted revised prescribing guidelines for all individuals to review and provide comment. When staff drafted these guidelines, they reviewed information from several existing guidelines and incorporated them into the board's revisions. In addition, staff incorporated information received at prior task force meetings. Several items needed expert input, such as what is an appropriate morphine equivalency that would raise a red flag, as there is varied opinion on this matter. There were several physician organizations in the group that could provide guidance and input on these guidelines and these types of questions. The meeting had representatives from the prescribing and dispensing communities, law enforcement, and other regulatory boards, including Dental Board, Pharmacy Board, Physician's Assistant Board, and Nursing Board. In addition, prior to the meeting, the board received written comments on the revised prescribing guidelines. There was a very lively discussion at this meeting on the guidelines, their intent, their purpose, and what needed to be included in them. The group overall thought that the guidelines needed to be broad enough to cover all scenarios that may occur. One member of the audience made a very good observation that the best practice is one patient, one physician at one time. Basically, this means that you cannot put every scenario in a guideline, but it needs to provide basic guidance to assist in making decisions in all situations. The other issue that needs to be clarified is the difference between treating acute and non-acute or chronic pain. At the end of the meeting, we offered everyone an opportunity to go back and continue to review the guidelines and provide their comments to staff. To date, staff have received several comments from several different organizations. Board staff will be meeting next week to review all of the comments received at the meeting and putting together the next draft for the task force. Board staff will also be meeting with some physician experts in the field prior to the next meeting so they can provide input in order to get a final document. As Ms. Kirchmeier stated today, the task force wants to complete the revision to the guidelines prior to the October board meeting. This will allow the board to hopefully approve the guidelines at this meeting so they can be sent to all physicians and posted on the board's website. During the course of this process, staff have been gathering some best practices for prescribing opioid medication. This is still a future issue for the task force that will be looked into after the revision of the guidelines. We think this process of revising the guidelines has provided the opportunity to have all stakeholders weigh in on this process in order to get the best product. Our goal is to have a document that can educate providers and assist in appropriate prescribing. Any questions?
Colleagues, any questions on Dr. Bishop's report? Seeing no questions or comments, are there any comments from the public? Seeing none, are there any comments from the telephone?
There are no comments in queue.
Thank you. Thank you, Dr. Bishop, and Ms. Yaroslawski for your efforts. We'll now move to agenda item 22, update on Physician Assistant Board. Dr. Bishop.
Thank you. Now my mouth is getting tired. All right. With respect to the personal presence regulation, Title 16 California Code of Regulations, the Medical Board is the agency that adopts any scope of practice regulations on behalf of the PA Board, and so it is with these personal presence regulations. The Medical Board held a regulatory hearing for this proposal at their February 7, 2014 meeting. Public comment received during the 45-day comment period was reviewed. After discussion, it was proposed to delete "or" in one section of the language. The board adopted this change, and there was a 15-day public comment period. At the Medical Board meeting in May, the members reviewed public comments received, and following consideration of comments received from counsel for the Attorney General's Health Quality Enforcement section, MBC staff recommended further clarification of the definition of immediately available. MBC members voted to approve the language but refer it back to the Physician Assistant Committee or Board at this point for consideration. The modified language was approved by the PA Board at their May 2014 meeting, and it was referred back to the MBC and noticed for another 15-day public comment period. Since no public comment was received, the rulemaking file is currently being finalized and will be submitted to the Department of Consumer Affairs for review and approval, and ultimately to the Office of Administrative Law. On behalf of the PA Board, I would like to thank members of the Medical Board and Board staff for their support of this regulatory change. With respect to the PA Board website update, the website design, Physician Assistant Board staff continue to work with the Department of Consumer Affairs Internet team to update the website. The Department of Consumer Affairs is requesting that boards, bureaus, and commissions within the department have similar looking websites. With respect to SB 352, Supervision of Medical Assistants, the Board has updated the website to reflect implementation of SB 352, which allows physicians to delegate medical assistant supervision to physician assistants, certified nurse practitioners, and certified nurse midwives. The website frequently asked questions section regarding medical assistant supervision has been updated to reflect the SB 352 changes. We have also included a new informational bulletin on the website to give more detailed information regarding this change in law. We continue to include a link to the Medical Board of California's website section regarding medical assistant laws and regulations. With respect to physician assistant licensure applications, board staff recently updated the paper allocation for licensure to reflect compliance with AB 258, which requires that we include in our application the following statement: have you ever served in the United States military? We've requested that the Breeze team make similar updates in our online application. The next Physician Assistant Board meeting is scheduled for August 18, 2014 in Sacramento. Are there any questions?
Questions from the members? Thank you for that report, Dr. Bishop. Are there comments from the public? Comments from the phone?
We do have one. It comes from Genevieve. Please go ahead. Genevieve, possibly your mute button's on.
We will take her comment.
Yes, it was.
Oh, there she is. Great. Here we go.
Actually, what I missed my cue. I wanted to speak on item 21.
We will take her comment.
Yes, it was. Actually, what I missed my cue. I wanted to speak on item 21.
She may have to mute.
She needs to mute the webcasting.
The webcasting. Yeah, she needs to mute the webcasting, the feedback loop. Genevieve, are you?
Actually, I lost feed. I have to read out again.
Okay, we will get her comment, and let's get in touch with her, and she can comment on item 21 at a later time, if that's all right. Yes. For now, the board will stand in recess for 5 short minutes, and we will resume. My iPhone tells me it is just one moment. 11:20. So at 11:25, we'll resume with Ms. Simone's report. Thank you.
Kim, I forgot about the legislative comment.
Order. This is a meeting of the Medical Board of California. We're resuming to our agenda. Item 23, discussion and consideration of legislation and regulations. Ms. Simoes?
Thank you, and good afternoon. Please refer to your legislative packets. First is just a little update. Currently, the legislature is on summer break, so while I did invite some offices to come to our meeting, a lot of people are taking vacation at this time of year, but we do have some dedicated staffers. GV is in the audience again today, and then Sarah Hutchell from Assembly BMP was in here earlier, so she may come back. So if you please refer to your tracker list. That's the list with the different colors. So the bills in blue are 2-year bills, or bills we have already taken positions on, so we don't need to discuss them at the meeting today. Bills in pink are our sponsor bills, so I'll just provide a quick update on those. Bills in green, we need to discuss and take a position, and there's one bill in orange that just may require a little bit longer of a discussion, so we'll do that one last. So let's move on to the board sponsor bills. The first bill in pink is AB 1838 Bonilla. And we have good news on that one. The governor just recently signed this bill into law, and this is the bill that would allow graduates of accelerated and competency-based medical school programs to be eligible for licensure in California if the program is accredited by the Liaison Committee on Medical Education, or LCME, the Committee on Accreditation of Canadian Medical Schools, or the Commission on Osteopathic College Accreditation. So this bill will become effective January 1st, 2015. If no one has questions, I'll move on to the next update. That's AB 1886, Eggman. This is the posting bill, and this is the bill that would allow the board to post the most serious disciplinary information, which is already public information, on the board's website. This bill was recently amended to address concerns raised by the California Medical Association and other provider groups. Concerns were raised that posting all public information indefinitely would be punitive, especially for information that is a lesser form of discipline or that is not considered discipline. CMA also raised concerns about that the existing statute was confusing and convoluted, which the board staff agreed with. So the author, sponsor, and CMA worked on amendments, and with these amendments, there's no opposition to the bill. And just to quickly go over the amendments, they do the following. They restructure the statute to reflect the current and historical information that can be posted to the board's website. They require malpractice settlement information to be posted over a 5-year period instead of a 10-year period. Require public letters of reprimand to be posted for 10 years instead of indefinite posting, and require citations to be posted that have not been resolved or appealed within 30 days, and once a citation has been resolved, to only be posted for 3 years instead of 5 years. This bill will next be heard in Senate Appropriations. So moving on to the next bill, if no one has questions on that. Okay, SB 1466 is the Health Omnibus Bill. So this just kind of contains technical amendments for all the health boards. So the portions related to the board are including the American Osteopathic Association Healthcare Facilities Accreditation Program as an approved accreditation agency, and striking schedule from existing law that requires physicians who perform a scheduled medical procedure outside of a hospital that results in a death to report the occurrence to the board within 15 days. This bill is moving through the process. However, earlier I had said some language was going to be included related to physician availability. This language was actually amended into the bill, and it would have allowed the board to go through the regulatory process for physician availability in all clinical settings, versus right now it's only for settings using laser intense pulse light devices for elective cosmetic surgery. The language was put in, but unfortunately it was taken out because concerns were raised in Assembly B and P. They thought this issue needed further discussion, so the omnibus bill does not include that language. So I just wanted to let you know that.
Yes, Doctor.
Jennifer, there is one new issue on the residency programs, that is that the AOA and ACGME agreed to one accreditation starting in 2015. So what that means that the osteopathic accredited programs can take MDs into their program starting in 2015. So we need to make sure that till they all become, by 2020, they all go into ACGME. But you got that gap where if an MD goes through an AOA accredited program, that we still consider that as postgraduate training. So I just want to see where we can put that.
Yeah, so this will fix that effective January 1st, 2015. So it will add AOA into there in addition to as an approved accreditation agency for hospitals.
No, that's for hospitals. I'm talking about residency programs, which is totally different. This is the first time those two agreed to have single accreditation eventually by 2020, but in 2015, some of the AOA accredited programs are going to allow MDs to go into those programs, which never happened before.
Well, I can talk to Senate BMP staff, and I don't know if at this point they'd be willing to put any other language because we're kind of reaching the end of session, but I can talk and see if it's, me and GV will meet and see if it's something that.
Yeah, I mean, if it doesn't happen now, as long as it happens by when this program starts, I'm okay, because I just I want to make sure that the MD graduates who go through an AOA program, we still consider that as a training program. So that's why.
Well, being that the other one wasn't controversial, I don't think that would be, but I will talk with staff.
Are there additional questions or comments from the members? on these two bills? Are there? Do you seek a motion to approve, to support? No? Okay, thank you.
Just updates. Okay, so we're going to move on to the first bill in green, and these are the ones that will require position. So AB 496, this is a bill that's actually a 2-year bill, and it was introduced in 2013, so we haven't talked about this one for a while. Originally, it would have previously reauthorized the task force on culturally and linguistically competent physicians and dentists in order to expand the task force's membership and charge to include the lesbian, gay, bisexual, transgender, and intersex or LGBTI community. However, this bill was recently substantially amended and would now only add to the existing cultural competency CME course requirement of understanding and applying cultural ethnic data to the process of clinical care to also include information pertinent to the provision of appropriate treatment and care to LGBTI communities as appropriate. The board could work with organizations that accredit CME courses to ensure compliance with the new requirement if this bill was signed into law. This bill does not expand the board's cultural and linguistic physician competency work group, but would require organizations that accredit CME courses to update their standards, if necessary, to meet the new requirements in the bill. Since this bill does not expand the working group convened by the board could only maybe include agenda items at future meetings to hear from organizations who have addressed the amended cultural and linguistic competency curriculum requirement. The board did support the previous version of this bill because the board believes it is important that LGBTI cultural issues be addressed by providers so physicians can provide appropriate care for all patients, and believes cultural competency is an important factor in the physician-patient relationship. So board staff is suggesting that the board continue to support this bill even though it's been amended. Please.
So I'd make a motion to include the language as given.
And I'll second.
To recommend support.
Yes. Right.
Okay, thank you. There's a motion and a second. Discussion or questions from the board? Yes, doctor.
I just want to make sure that this doesn't mandate any CME. Is that correct?
No, so it just changes the requirements that CME must meet. So right now there's certain cultural competency requirements that all CME must meet. This integrates into one of those requirements in LGBTI issues. Right. So it's...
Great, thank you. Are there additional questions or comments? Seeing none, are there comments from the public on this bill? Are there any from the phone?
We do not.
All those in favor?
Aye.
Aye.
Opposed? Abstentions? Motion carries. Next bill.
Thank you. Next bill, AB 809 Logue. The Telehealth Advancement Act of 2011 was signed into law as a result of AB 415. This bill would delete the requirement included in the act that is now an existing law that requires physicians, prior to delivery of healthcare via telehealth, to verbally inform the patient at the originating site that telehealth may be used and obtain verbal consent. This bill would now require healthcare providers, prior to initiating the use of telehealth, to inform, and it doesn't necessarily have to be verbally, the patient at the originating site about the use of telehealth. This bill would now allow the healthcare provider to obtain consent in writing for the use of telehealth as an acceptable mode of delivering healthcare services and public health during a specified course of care and treatment. This bill would also specify that it shall not preclude a patient from receiving in-person healthcare delivery services. This bill would allow the Telemedicine Act of 2011 to be implemented, which will, as intended, which will help improve access to care via telehealth. The board previously had a support position, and these amendments do not adversely affect the board or the reason why the board supports this bill. So staff is suggesting the board continue to support this bill, but I need a motion.
Is there a motion from the board to support? So moved. Dr. Kraus, is there a second?
Second.
Second, thank you. Any board discussion, questions?
So I just want a point of clarification. That this bill now says that a doctor can mandate that they will provide services only via telehealth and then it has to be accepted by the client?
No, so it's kind of the opposite, that the client has to, what this does, before it was every instance of telehealth, which was a problem for providers. So now that says before they initiate it, originating site. So it's one time for that course of treatment, they have to get verbal or written consent, and then they can, but it's not a mandate. It says that's part of what I said is that it actually includes specific language that it shall not preclude a patient from receiving in-person healthcare services. Mm-hmm. So in the past, the board hasn't really had concerns about the consent requirements because we've always said that a physician is held to informed consent, whether or not specifically says so in the telehealth requirements. The standard of care requires physicians to provide whatever the appropriate consent is to their patients. So even though they're kind of changing the way this consent is given just in this telehealth requirement, we've never had issues at this section being changed. But from when I talked to the author's office, Kaiser and CMA and some others had delivery issues the way this was worded before. And so what this bill is intended to do now is to fix those issues to allow this Telehealth Act from 2011 be more properly implemented. And it's the same author from 2011 that's now trying to fix it in 2014. So
Thank you for that.
Thank you.
If there are no additional comments from the board, I have a card for this item. Yvonne Chung, CMA. Hello. Hi.
Yvonne Chung with the California Medical Association. We are currently neutral on this bill. We did want to raise two issues for consideration. There are a couple amendments that are going to be forthcoming on this bill as well. Currently, we're neutral because we feel the bill language, as it's proposed to be amended, is really broad enough to allow us as an organization to continue recommending to physicians that they obtain consent for each course of care provided via telehealth. We believe that's the best practice, and that's what the bill currently says. They're proposing amendments that basically broaden that language, and our concern is that the amendments could be interpreted to require consent for each use of telehealth once you remove, quote, during a specified course of healthcare and treatment. We think that kind of defeats the purpose, and it takes us back to current law again. So it's an interpretation of how broadly you're going to define when consent needs to be given. We don't want to blanket telehealth consent going forward for the rest of the patient's life, obviously, but we also don't think that every time you pick up, every time something you pick up the phone or you make a connection that you have to separately get informed consent. So we think that including the phrase specified course of treatment kind of provides some boundaries around, if you're going in for, a series of dermatology treatments, you do it once at the beginning and then going forward for that course of treatment, that consent would be in place. Thank you.
Thank you. Are there additional comments from the public? Those present? Are there any comments from the telephone?
We have no comments in queue.
All those in favor of the motion to support?
Aye.
Opposed? Abstentions? Motion carries. Next bill.
Okay, next bill is SB 1116. And this is the bill that previously would have allowed physicians to donate an additional $75 to the board for the purposes of funding the Stephen M. Thompson Loan Repayment Program. Amendments were taken to address concerns, and this bill would now require the medical board by July 1st, 2015, to develop a mechanism for physicians to pay a voluntary contribution at the time of application for license or renewal to the Stephen M. Thompson Loan Repayment Program. Currently, a physician can donate more than the mandatory $25. However, this information is not included on the board's initial licensing or renewal application. This bill will ensure that physicians are aware of their ability to donate additional funding. And the board was actually already planning on doing this, and the board supported the previous version of this bill, and staff recommends that the board continue to support this bill and any other measures that help fund or make improvements to the STLRP. So I need a motion.
So moved.
So moved. Is there a second? Second, Dr. Lewis. Discussion by the board? Seeing none, are there any public comments? No public comments? Comments on the phone?
We have no comments in queue.
On the motion to support the bill, all those in favor?
Aye.
Opposed? Abstention? Motion carries. Next item.
Okay, the next bill, SB 1243, Lou. It started off as a sunset review bill for several boards under DCA. However, language was recently added that will affect all boards under Department of Consumer Affairs. Purpose of the language is to increase transparency of information distributed by the department, and this bill would require DCA, the Attorney General's Office, and the Office of Administrative Hearings to submit specified reports to the legislature on an annual basis. The information required to be reported by DCA is modeled after the Medical Board's existing law, Section 2313, that requires the Medical Board of California to report specific data in the board's annual report. So basically, it just copied and pasted our language into the general code sections that apply to all boards, and it would require DCA to report that information. So I'm going to quickly go. There's some provisions in here that might be of interest because they affect board members. I'm going to go over those, but they don't necessarily just impact the board. So first, this bill would require agencies under and within DCA to provide written notice of a board meeting by regular mail, email, or both, and would require an agency that plans to webcast a meeting to include in the meeting notice the intent to webcast the meeting. However, this bill would allow the meeting to be webcast even if the information is not included in the meeting notice. This bill would expand the existing authority of boards to request telephone disconnection for advertising of unlicensed activity to any form of advertisement, not just to those in a telephone directory, because obviously that's a little outdated, and provides this authority to all agencies under and within DCA. This bill would require DCA to provide an opportunity for an employee of an agency comprising DCA who performs enforcement functions to attend an enforcement academy on an annual basis. This bill would require DCA to develop the Enforcement Academy curricula in consultation and cooperation with the AG's office and Office of Administrative Hearings. This bill would require the Department of Consumer Affairs to submit a report of the accounting of the pro rata calculation of administrative expenses to the appropriate policy committees of the legislature on an annual basis, and starting on or before July 1st, 2015. And this bill would also require DCA to conduct a study of its current system for prorating administrative expenses. And as you know, all boards under DCA are charged pro rata. And then the next part, like I already said, it takes our section, so I don't think I need to go over every reporting requirement that we do in our annual. It's basically the information you see in the annual report. It's trying to make it more standard across all boards under DCA, so it essentially right now copies and pastes it from our section to the general code section. So that's all listed in the analysis if you have questions on that. And it also has some reporting requirements for the AG's office and for the Office of Administrative Hearing. And the kind of reporting that it requires, I won't go through everything, but it's things like the number of cases referred, the number that no action is taken, the number of accusations filed and withdrawn, the average number of days it takes to get to various steps of the enforcement process, and the same type of reporting information for OAH when it comes to their hearings. And so that is all information that would be reported to the legislature on an annual basis. And then lastly, this bill would require the Department of Consumer Affairs to develop a board member mentor program where experienced board members will be trained to act as mentors to newly appointed board members. A mentor member should be assigned to a new board member who serves on a different board, and a mentor can be a current or former board member. So the purpose of this bill, like I said, is to increase transparency, enhance enforcement processes, procedures, and training, and ensure that performance statistics are being reported in a standard manner across all boards. This bill also takes steps to improve and look at DCA's pro rata methodology that all boards are required to adhere to. We do have some technical concerns just with when you cut and paste into something to apply to all boards. Some of the stuff, for instance, like some of the peer review reporting stuff only really applies to our board. And so there's going to be, I don't really think we need to go over and list them all, but there's just some little technical things that would make it easier to implement. And the reason why I don't want to list them all is because more may come up as we're kind of talking about this. We met with DCA and some of the other boards kind of working through like Breeze and how this can all be and the reporting stuff can be done. But I am suggesting that we take a supportive amended position on the bill and just allow us to work with the author's office and DCA to get those technical issues fixed.
I'll make the motion, but I want to be able to speak on the
Absolutely. So there's a motion to support if amended.
Yes.
Second.
Starskowski, there's a second. Thank you. Discussion?
Yes. So there's a couple of things that I just want to make sure your attention is drawn to it. I'm sure yours is, but members sitting here are as well. I think it's an interesting idea that there's collegiality among DCA boards and bureaus, but the idea that these boards, I don't know about you guys, wanting to serve as or be mentored by, but the idea that it's mandated that we should be mentored by other members of other boards, those that are new and old, I'm not so sure that that's necessary or function. It will function. So I just want you to be aware that I have concerns with that one. Okay. I also have concerns with the enforcement staff going to retreats on an annual basis. That's a great idea. Time of the essence, though, to take in a specific amount of time out of the work month, work year is of concern to me. So I would hope that enforcement can do what enforcement does, and that he's gone. My tired mouth is gone, I guess. I would just like to call attention to that when you're doing that, that maybe a time frame is not necessary. I'm concerned by, we're paying these bills that time, and there's going to be a lapse in workload.
And I did not comment on those sections because those were more, yeah, no, that's fine. Enforcement Academy, I know is something that happens now that DCA offers, but I think the point of the language, correct me if I'm wrong, King, the point of the language is to make sure it happens on a regular basis. Like sometimes they don't maybe have enough staff or.
I think the problem that Ms. Yaroskovsky is talking about is that it talks about annually.
It's a special.
And to have the staff go over and over again, I think is what you're alluding to. Just trying to find that place.
You can make that notation when you speak with the author.
Yes.
Doctor?
This bill has something good, something very worrisome. I think good is that cooperation and transparency are good. It's a good idea. Right. But micromanagement is a very bad idea. So I think staff needs to work with the author to eliminate as much of this micromanagement as possible and leave the cooperation and transparency so that it's for the benefit rather than mandating this and this. A lot of micromanagement doesn't work and it just hinders the workload.
But I would like to recommend that if DCA would like to host an annual meeting of all the boards and bureaus for them to come together for a social occasion, it might be a nice idea with some kind of informative speaker. It's been done in the past, once or twice a year. I mean, I know I've attended one. It was not all that. It was interesting, but as far as the social opportunity, that's a nice idea.
And I did just want to point out. Oh, sorry. No, go ahead. I did just want to point out one thing, that the Enforcement Academy training is just offering it on an annual basis. So it doesn't mean they have to attend on an annual, but that they have to offer it to their employees.
I was concerned about that. It's.
Thank you.
Okay.
Thank you. Are there comments from colleagues to my left? I just want to make sure. Seeing none, are there? Oh, the motion is to support if amended. Are there comments from the public? No comments from the public present. Telephone?
We have no comments. Thank you.
Thank you. All those in favor of the motion?
Aye.
Opposed? Abstentions? Motion carries. Thank you.
And I did just want to say that the staff working on this bill is in the audience, so he heard your concerns. Okay.
Thank you.
So moving on to the next bill, SB 1262 Correa. This is the medical marijuana bill that we heard last time, but it's been substantially amended. So this bill would put various licensing and enforcement requirements on medical marijuana dispensaries and cultivation facilities. It would now create a Bureau of Medical Marijuana Regulation in the Department of Consumer Affairs, and that would be the regulatory agency performing the licensing functions and some of the enforcement functions. But it also gives local agencies a primary responsibility for enforcement of Bureau standards in accordance with Bureau regulations. But my analysis is going to speak to the requirements on physicians recommending medical marijuana and on the board. So that's what I'll cover in my presentation today. So SB 1262 would require the board to include in its investigative priorities cases involving repeated acts of excessively recommending marijuana to a patient for medical purposes without a good faith examination of the patient and a medical reason for the recommendation. This bill would prohibit a physician from recommending medical marijuana to a patient unless that person is the patient's attending physician. An attending physician is actually defined in the Health and Safety Code, so there is a definition for that. This bill would also subject physicians recommending medical marijuana to the laws in Business and Professions Code section 650.01 and would not allow a physician to accept, solicit, or offer any form of remuneration from or to a licensed dispenser, producer, or processor of cannabis products in which the licensee or his or her immediate family has a financial interest. This bill would not allow a physician to advertise for medical marijuana physician recommendations unless the advertisement contains a specified notice to consumers and meets the requirements of Business and Professions Code, Section 651. Lastly, this bill requires the medical board to consult with the University of California's Center for Medicinal Cannabis Research on developing and adopting guidelines for the appropriate administration and use of marijuana. So as you can tell, this bill has been significantly amended, and it really doesn't expressly spell out what a physician must do before medical marijuana is recommended like it did previously. Including there was a requirement before that an in-person patient exam must be conducted, and that's no longer in the bill. Although it does still place anti-kickback and advertising restrictions on physicians and includes medical marijuana recommendation information, the board's priorities. The bill does require the board to consult with the CMCR, which is the UC program for, and I can give you more history on that, but it's in the committee analysis, but does not expressly require the board to work on guidelines. So how we see it is what we would do if this bill passed. We have a statement that's on our website right now, policy that the board adopted. If this bill were to pass, we would work on updating that policy and perhaps consult with this UC group when updating that policy. However, staff is suggesting that we now take a neutral position because it doesn't contain a lot of the guidelines for physicians on what they must do before. A lot of the stuff that we liked in there that held physicians to before recommending marijuana is not in there anymore. And so, I mean, it's up to the board, but staff is suggesting that we go neutral on it.
Thank you for that report. So a quick question for me is, how does it stand in relationship to the Amiano bill? Wasn't that, we talked about that?
Yeah,
it was
so
the Correa and the
Amiano-
Amiano,
yeah.
which we supported, the Amiano.
Yeah,
Okay.
and we had an OUA, but right after we took the OPOSA list amended, this bill got substantially amended, so I never really got that position out because it was no longer really applied. So Amiano bill is no longer alive.
Okay.
And so Correa is working with Amiano's office on this bill now. And so Amiano's like the primary co-sponsor, and his staff has called, Amiano's staff has called me on this bill. They know that we like the inpatient exam. They know we like some of the other stuff, but it doesn't include it yet. So that's why I'm suggesting we take a neutral position. It really just doesn't have a lot. I mean, it adds it to the board's priorities, but since we treat medical marijuana like any other controlled substance, that's kind of already in the board's priorities, that they should, be doing the appropriate prior exam and that kind of thing. So that's already in the board's prior. It does have the advertising stuff in there, and so that's something that's in there, but the rest of the bill really deals with the regulation of the dispensing and cultivation and this new bureau within Department of Consumer Affairs, which really doesn't affect the medical board.
Last question for me. Is Amiano a potential co-sponsor of this bill?
He is a co-sponsor.
He is a
now,
co-sponsor.
yeah.
Thank you. Ms. Yaroslawski.
Just one clarification, because I thought I heard in the beginning that what this bill does is that, in fact, you cannot make a recommendation unless you are the primary care provider. And then you said at the end that that's not, it's exactly the opposite, so I apologize, but.
So what it is a definition in the Health and Safety Code as an attending physician, and it's the section of the Health and Safety Code that's talking about the medical marijuana program for the Department of Public Health. The attending physician is really broad. It's not a primary, I can read you the.
No, but they're not using what our definition is for the physician and the role and responsibility of the physician with their patient.
No, they're using the definition from the Health and Safety Code, and it's pretty broad. I mean, I can read it, but it's anyone who's taken responsibility for some aspect of care and who's conducted a medical exam of that patient.
And maintaining of medical records and maintaining of follow-up exams and all the other stuff. Did they take out that part? Is that what you're saying?
Yeah, that all came out.
So all of the stuff that we had in before that we went along with, that we supported, is now out of this bill.
Correct.
Could it go back in with a neutral position, or it won't go anywhere?
The problem is it's just really late in the legislative session. I mean, they have taken these amendments, and the bill is in the form that it is now to try to address concerns. So putting the language back in at this point may not happen. I mean, they know that Amiano's office knows that we really like certain areas of the Amiano bill, and he said he will try to get those in if he can, but at this point.
Well, my concern is that since we have something already on the books, that for them to go parallel with what we have would be smarter than to take what we have and try and make it less functioning. That was my concern.
Yeah, the stuff that
a neutral support is not a negative support, but it's a positive support.
Yeah, the stuff that we really liked was in the Amiano bill, a lot of it, and then the Correa bill, we had some concerns. It was like, I don't know if you remember, it was like the levels and all,
prescriptive.
Yeah, very prescriptive. So they kind of started over with this bill, and so it doesn't include much of the Amiano bill other than adding it to our priorities.
Dr. Lewis?
Okay, tell me, is there a difference between recommending neutral versus opposed unless amended? Do they say the same thing, or in your opinion?
So opposed unless amended is a much stronger position, and it's more of a negative position. And both of these offices have been really good in checking with me on stuff. They know what we like, but they've been good not to put stuff in here that we don't like. And so I feel like if we take an opposed, and this is just my recommendation, but I feel like if we take an opposed unless amended position, it's going to be like a negative thing when they've really tried to like keep me informed and make sure that they don't put stuff in there we don't like, although it doesn't have everything that we really like.
But the good faith exam is not in this one.
It is in the priorities, but it's not in the requirements of here's the things a physician must do before they recommend
Which is
marijuana.
a big part of what we wanted in that bill, I would think, but okay.
However, it still goes back to, we already have 2242.
Yes, we already have that.
Requires an appropriate prior examination.
Before dispensing.
Right. What we were hoping to have that was in the Amiano bill that would really actually assist us in the medical marijuana cases is the fact that it did have a provision that said it had to be an in-person visit. We see a lot of these that are happening via Skype, via telephone,
iPhone,
where we're getting, and so we were really hoping for the in-person language of the Amiano bill. So that's what we were really pushing for. I think for everything else, we already have the standard of care for prescribing, which hence goes to the recommendation as well.
Thank you.
Okay,
Is there a motion?
Motion, I move recommendation to remain neutral.
Neutral. Second, thank you. We've had discussion, but is there any addition? I'll get any discussion, further discussion from the board? Seeing none, any public comment? Comment from the phone?
We do have a question. It comes from Genevieve. Genevieve, please mute your computer portion of before speaking. Your line is open. We do have a question. It comes from Genevieve. Genevieve, please mute your computer portion of your line is open.
Yes. I'm a little bit concerned about this bill. First of all, technically, marijuana is a Schedule I drug, and technically it's not to be ordered, and I think there is to be a lot of clarification in bills dealing with marijuana, and I don't think this is clarified enough. Thank you.
Thank you. Are there additional comments?
There are no additional comments.
Thank you. All those in favor of the motion?
Aye.
Opposed? Abstentions? Motion carries. I think we have one more bill.
We are going to the last bill in orange. That's
Great.
SB 492.
492.
Yeah. So as you know, we talked about this last time. It's been substantially amended since we've taken an opposed unless amended position on this bill. Just as a point of process, are board members okay with me just hitting the highlights? I mean, all the requirements are in the analysis. I can just hit the major issues. Is that okay with the members or in the chair? Okay. Okay, so I'm going to go through. So SB 492 originally would have deleted the definition of the practice of optometry in existing law and would have expanded the scope of an optometrist. This bill was amended and would instead generally revise the Optometry Practice Act to clarify and expand the optometrist's scope of practice and create an advanced practice optometry certificate. So the high level things that this bill would do is allow an optometrist to provide habilitative optometric services, allow an optometrist who is certified to use therapeutic pharmaceutical agents or TPAs to diagnose and treat the human eye or any of its appendages for specified conditions. It would delete the requirement that optometrists can only use a specified list of therapeutic pharmaceutical agents and would instead authorize an optometrist to use all TPAs approved by the FDA for use in treating eye conditions consistent with the scope of practice limited to a maximum of 5 days. It would, delete the list of specific tests that TPA certified optometrists are allowed to order and instead permit optometrists to order any appropriate laboratory and diagnostic imaging tests necessary to diagnose conditions of the eye or adnexa. Okay, delete the restriction on the use of needles and the removal of foreign bodies from the eye. It would require the Board of Optometry to certify any optometrist who graduated from an accredited school of optometry before May 1st, 2000 to perform lacrimal irrigation and dilation after submitting proof of satisfactory completion of 10 procedures under the supervision of a certified optometrist. It would require the Board of Optometry to grant a glaucoma certified optometrist a certificate for the use of specified advanced procedures after the optometrist meets specified requirements. And so I'm not going to go over a lot of the requirements, but at issue with some of the interested parties in this bill is the requirements for optometrists that don't go through one of these new advanced programs. And so one of the main issues is the clinical experience. And so right now this bill would require between 20 and 35 clinical eyelid or nexa surgical training procedures, between 18 and 25 laser training procedures, and between 6 and 12 injection training procedures. And this is, has been one of the contentious issues, is how much clinical training the optometrist is required to get on what procedure. So this has been like a major issue of contention. That's why I'm going over this. So now what the bill would do to kind of address that is require the Board of Optometry to convene an advisory committee to establish the exact number of training procedures. So there's certain requirements on this advisory committee, but that's how the author is trying to address kind of the contention on this. It also defines the term advanced procedures and lets the procedures be done like therapeutic kind of lasers and those kind of procedures. So I won't go through all of them, but kind of gives you an idea. And it also requires the Board of Optometry to grant to a glaucoma certified optometrist a certificate to administer immunizations, but that optometrist would have to meet certain training requirements in order to administer the immunizations. So like I said, in the Assembly B&P committee analysis, I kind of explained the background that they had all these meetings. In the interim, they convened 6 separate meetings. They heard expert testimony, discussed key components of advanced practice, laser procedures, surgical procedures, immunizations and injections. The committee staff was very involved. They did a tour of the UC Berkeley School of Optometry. Formal discussions concluded in January without consensus. And so basically, unfortunately, the parties weren't able to find a mutually agreeable objective standard to bridge the remaining distance. So basically, the last amendments kind of just reflected what the author and the sponsor wanted. So this bill still expands the scope of practice of an optometrist by authoring advanced practice certification and by allowing optometrists to treat different disorders non-surgically and surgically, treat eyelid disorders and other things. So it's basically still a big expansion in the scope of practice, and it hasn't changed a lot other than it's kind of changed the training and things like that. We're in kind of a different position than we were last time because there's not a lot of time left for negotiation, and both sides have kind of I'm not sure that a lot of negotiation will happen between now and when the bill makes it through the legislature. So what I'm suggesting now is that because we're at this point in the process that we take an opposed position on this bill.
I'm going to move to take an opposed position on this bill.
There's a motion to oppose. Is there a second? Second. Second. Discussion, colleagues, on the motion? Doctor?
Let me share my conflicts of interest. I am a trustee of the California Medical Association. I'm an ophthalmologist. I've actually been dealing with scope issues ever since I've been in practice. The other conflict I have is that in my own practice, most of my patients are referred to me both by ophthalmologists and optometrists for secondary and tertiary care of patients who have problems, and sometimes the problems are complications of care. So if this bill were to pass, it would actually be to my financial benefit. But as a member of the board, and all of us have a duty and obligation to set aside our personal interests and first and foremost to protect the public. Regarding the pathway of this bill in particular, as you know, this was put over to the second year. This is the second year. And more than 6 months ago, a committee was convened to sit down to bring all stakeholders and all interested parties together to discuss on a rational basis what would be required to have allied health professionals, in this case optometrists, acquire adequate skills under supervision to safely perform a selected number of procedures and perform them such that all of us were convinced that we had the same safety, efficacy, and public protection. And we were not directly part of that. Initially, the medical board was invited, and for reasons that are unclear to me, the medical board was specifically excluded from participating in that discussion. And I know from secondhand information that there was political pressure on the CMA, on the California Academy of Eye Physicians and Surgeons, and even on the National American Academy of Ophthalmology to reasonably create a platform by which these things could be accomplished. And those people who were involved in it put in many, many hours and a lot of hard work to come up with a reasonable program of supervised education, acquisition of skill sets, so that we could all be comfortable that these procedures would be carried out safely. And when this was brought to the Health Committee, basically the author of the bill rejected it. And the author of this bill has previously submitted bills where, in essence, the expansion of optometric scope would be to include everything, not only that an ophthalmologist does, but that a general physician would do if someone presents with visual symptoms. So there comes a point where if there's inadequate assurance of public protection, and if we're not even invited to participate in the process, that I don't see that this is anything that we can amend or revise in this session that could possibly allow us to support this. So I'm firmly in support of the opposed position, which has been moved.
Thank you. Thank you for those thoughtful comments. Are there any additional comments? Seeing none, are there public comments on the motion? Any comments on the phone?
We have no comments on the phone line.
All those in favor of the motion?
Aye.
Aye. Opposed? None. Abstentions? Motion carries. Thank you. Does that conclude this report?
That concludes this report.
Thank you. Oh yes, Doctor.
Before we excuse you, I'd like to thank you, but I'd also like to state that many of us have frequent discussions with Jennifer, and apart from admiring the great work that she's doing, it came to my attention recently that our bills evolve rapidly and move from committee to the floor. And basically, the structure of our board is that we take and revise and reconsider our positions on a quarterly basis. And I think sometimes that puts Jennifer in a position where she may not be comfortable in testifying at a hearing or on the floor if the bill is significantly different from its form when we had our previous quarterly meeting. And I've suggested, and I hope the board would approve, that the executive committee over time really develop a compendium of policy, whether it be a policy on scope of practice or policy on disciplinary procedures, but a compendium of board policy that Jennifer can always go back to and always say, this bill in its present form differs with policies of the Medical Board of California in such and such a fashion, without having to be absent from the table. So if I could, if you would entertain, if you think it would be best accomplished by motion.
Well, here's my commitment to you, Doctor. And you could hold us to account. And that is, I agree with your suggestion. And I think it would be helpful. We did a policy yesterday for that very reason, yes. So at our next executive committee meeting, it will be the top agenda item for discussion.
Thank you.
Yes, okay. Because I agree with it.
And I also like to echo Dr. Krause's compliments of Jennifer. I know she sometimes gets phone calls and why this and why that, and she's very gracious and accommodating. And I think I can speak, our commitment is to provide more backup so she's not out there, you know, alone. And I think you'll see more involvement from board members to be with you, to be a partner with you with this effort. Thank you.
Thank
you. Dr. Yip?
Is that the what's an open meeting act prevent her from like soliciting opinion from board member on a regular basis if there's question about certain bill and input, not to vote on it, things like that? Almost like discussion today.
No, it doesn't. One good thing about having board members in multiple different specialties is that Ms. Simoes can actually contact you and get opinion on this. I know with SB 492, we've worked very closely with Dr. Kraus and having him review things for us and working with him on items. We've also contacted other members when we have bills come up and it's within their specialty to assist us because we don't have the technical knowledge. We can sit and look at it and kind of put our points together just from historical. But we do contact other board members, and the Open Meeting Act doesn't stop us from contacting the one member and discussing the issue. It would be if you started contacting other members.
Right, that's what I'm saying, not one member. Like if she's questions actually sent to all the members, even though we are not expert, but we may know something about it for input. Is it a violation if she email to all the members an issue?
I can email and BCC the board members, and then you can respond directly to me. So that can always happen. Or if you see a bill and you have questions, or you have information or pointers that might help, you can always contact me too and email me. That it's appreciated.
The conflict comes when, and Dr. Yip, I'm hopeful that all members understand this, is that when we contact and we speak with each other.
Mm-hmm. Right.
So it's always appropriate for us to talk with staff as much as we feel necessary, for them to talk with all of us as they see necessary. We cannot communicate more than two of us together on any issue.
Council?
And that applies also to serial meetings. So if you contact Barbara and it's just the two of you, or I'm sorry, Ms. Yaroslavsky, and then you contact Dr. Bishop, that's considered a serial meeting, and that's strictly prohibited.
Right. So I don't talk to anyone, so don't worry.
I think the members, we went through our training. It's a constant education and re-education on the public meeting act, the Brown Act. And but there's ways of interfacing and having that dialogue. Thank you for that report.
You're welcome.
We'll go on to item 24, agenda items for the October 23rd, 24th, 2014 meeting in. Oh, we have 23B, Pete? What is 23B? I'm sorry. I apologize.
Sorry.
I apologize, Jennifer.
So 23B is in your board packets, and it's the status of regulatory actions. And so there's a matrix in your board packets. So if anyone has any questions on that matrix, I'd be happy to answer.
Update. Are there any comments from the board? Seeing none, are there comments from the public on the matrix? Seeing none, any comments from the phone?
We have no questions in queue.
Thank you. Appreciate it. Now on to item 24, agenda items for the October 23rd, 24th, 2014 meeting in San Diego. Items for the next agenda will include, but not limited to, the legislative proposals and regulatory hearings on disciplinary guidelines. Do members have any additional agenda items for the October board meeting? This is not your last chance to propose any, but if there's anything now that you wish to share.
I'd like to know whether the Cures update is a standing agenda item or not.
We can make it part of it.
I think I'd like another update on Cures. I think that would be very helpful.
We can include it in, it's outside of your jurisdiction, obviously, but we could include it in your report. That's a good suggestion. Thank you, Dr. Lewis.
Very welcome.
Any other agenda items or suggestions? Is there any public comment on? Yes.
I don't know if this is, what I would like is a report or a discussion on the fictitious business license, if it is in fact meeting the needs of our stakeholders, and if not, how we can either convene an interested parties meeting or something so we are clear on the roles and responsibilities of the physicians and their knowledge of the implementation and use of fictitious business licenses.
Okay, thank you. I'll look over to my right. Any other suggestions? Again, this is not your last chance. You can contact our executive director. To the left here? No? Any comments from the public on this?
Excuse me, clarification.
What?
Fictitious business license, not fictitious names.
Yes,
versus
we understood. Yes, thank you.
My-
Thank you for that clarification. We would have had the wrong hearing. Any members from the public to comment on item 24? Seeing none, any comments from the phone?
We do have one person queued up. It's Genevieve. Please go ahead.
Yes, I wanted, actually, I was trying to speak to item SB 492,
Okay.
and I'm glad to hear that you're opposing it because that's probably one of the worst bills I have seen in a long time. An optometrist does not have enough background education, either didactic or clinical, to extend their performance on those issues. So I'm really glad that you are opposing. Thank you.
Thank you. Are there any additional comments from the phone?
No comments at this time.
Thank you. A point of privilege before I move to item 25. I wanted to thank everyone and my colleagues for being here at this meeting, our quarterly meeting. Also thank the public, interested parties, the patient advocates, our friends at the Department of Justice and Department of Consumer Affairs, senior legislative staff. And I always like to just thank the member staff that are here, Lisa, Jennifer, Caesar, Miss Webb, Miss Dobbs, our counsel. Thank you, Regina, Cassandra, Kurt, Susan, and Kevin. And our friends at DOI, Renee, Laura, Anna, and Nicole. Thank you all for being here. And without objection, the meeting is adjourned.
Thank you.
Thank
Right.
you.